So, sir, it's 3, 2, 1. We are live now, sir. Over to you.
Okay, good morning all. We will be having a posture presentation for AFPICON 2022 happening in this room. I would like to welcome the chairpersons and the posture presenters for the day.
Sir,
Today,
we have lost your voice, sir.
sorry. Am I audible now? Hello?
Hello.
Hello? Am I
Sir, can you
audible
try
now?
without earphone once?
Hello?
Hello.
Hello? Am I audible
No,
now?
sir. No, sir, you are not audible.
What about now? Microphone settings
Dr.
is
Nadeem, you're audible to us.
okay.
Okay, now you are audible, sir.
Okay. Thank you. I would like to welcome the chairpersons and the presenters for the day. I'll just brief the timings for the posture presentation. That's from now, we'll be starting with the presentation, and each presenter will get 8 minutes for presenting and discussion. After 10 minutes, after 8 minutes, we'll be ringing a bell, and after 10 minutes, the posture will be changed. We'll be having 8 presentations before inauguration starting from now, and till 11 a.m. we will be having 8 presentations, following which inauguration will happen. After 11:30 we will be having the remaining presentations. First of all, I would like to welcome the two chairpersons for the first initial 8 presentations. We have eminent faculty Dr. Hemant Saluja for chairing the session. Dr. Hemant Saluja, who has authored 2 books and having 27 years of experience, and he is a faculty at National Board. Also, he is a faculty at MRCGP South Asia Board. He is an executive member of Delhi Diabetic Forum and also joint secretary of IMA New Delhi branch. And he is also the scientific chair for Delhi chapter of AFPI presently. I welcome you, sir. Also, I would like to welcome the second judge, that is Dr. Serin Kuriakos, who has done his DNB from Lutz Hospital, Kerala, and has completed a certificate course in clinical epidemiology and statistics. He is the national chair of the Spice Route India movement and is executive member Spice Route A South Asia region. He was one of the founder executive member of AFPA Kerala and was the secretary of AFPA Kerala chapter from 2017 to 2020. He was the organizing secretary of Third National Conference of Family Medicine and Primary Care FMPC 2017. Dr. Serin was awarded AFPI Young Doctor Award in 2017. He has created AFPI Kerala website, AFPICON Kerala websites, FB page, media cell, and YouTube channel. He is currently working as Epidemic Intelligence Service Officer, National Center of Disease Control, New Delhi. Over to you, sir. Dr. Hemant Saluja and Dr. Serin Kuriakos will take over the poster presentation from postures 1 to 8. Thank you. Imagica team can display the poster number 1.
Yes, just a minute.
I will just say the order. The presentation is like Dr. Preeti, Dr. Bino, Dr. Melinda, Dr. Ashwati, Dr. Navina, Dr. Daisy, Dr. Bushra, and Dr. Anuna will present in the order 1 to 8. Thank you.
Is it visible?
Yes, your poster is visible. I think Dr. Preeti can start with.
Good morning, everyone. Today, I'm presenting a poster which is based on a comparative cross-sectional study regarding the knowledge, attitude, and practice on cervical cancer screening and prevention between patients attending the OBG outpatient department in my hospital and the nursing staff working in a tertiary care hospital. So, about the rationale of the study, as you all know, cervical cancer is a very common cancer among women, which is largely preventable by proper screening and early detection and diagnosis. So if it is detected in an early stage, it has a very good prognosis. And so I wanted to know how much the general population and the nursing staff are aware about this condition. Also, nursing staff being in a healthcare setup, they should be more aware about this condition, and they should serve as a source of tool for health education and promotion among the public. So I took 100 population from the nursing staff working in my hospital and 100 women attending the OPD, and compared the knowledge, attitude, and practice between this population by using a questionnaire which was translated to Malayalam, and each questions was explained separately, and their attitudes and their informations were collected. So the result what I obtained is, as expected, the nursing population were having a good knowledge regarding the cervical cancer screening and prevention. But though the general population were having a decreased or comparatively reduced knowledge regarding the cervical cancer, the population had a good attitude after they were given more awareness. They were having a positive attitude towards getting a screening done. And the practice was also more in the population group. Out of 100, about 22 of the patients had undergone a cervical cancer screening pap smear test, and only 8 has gone among the nursing staff, which showed a statistically significant difference in practice between two groups. The main reason why the nursing staff has not undergone a test was because they were not having enough symptoms. They thought they were not having enough symptoms, and among the population group, it was mainly because of lack of knowledge and partly because of absence of symptoms, which brought them to the OBG clinic. So concluding, I wanted to say that cervical cancer is a largely preventable cancer among the women, and women needs to have a good adequate knowledge regarding both the cervical cancer screening practices. So even though the nursing staff were having adequate knowledge, they were not enough motivated to get that screening done, while the population, they were having poor knowledge, but still after getting a proper awareness, they were ready to conduct more tests, and their practice was also good. So I want to conclude the study by saying that we have to motivate our healthcare workers in getting more awareness, as well as motivate them to get the practice done, and also use them as a health education tool to educate our general population. And we have to start more health education programs, and each among us, we all are family medicine doctors, we have a major role in educating our population regarding all these screening methods, and we have to educate our women regarding the various aspects of cervical cancer screening, and it's promoting them in doing a test done. Thank you.
Hello, Dr. Preeti.
Hello.
Am I audible?
Yes, sir.
Hello.
Hello, yes, sir. Audible, sir.
Okay, nice presentation. I have, what was the size of your study population?
It was 100 from the staff group and 100 from the population group, sir.
100 from the population. How many questions were administered?
18 questions, sir. 18 questions with multiple options given under each question.
You only asked the questions
Yes,
to
sir.
both groups.
Yes, sir.
To
Yes,
both groups.
yes, yes. Sir.
Okay, so your study says that despite having the knowledge, the staff are reluctant to get to undergo screening, right?
Yes, sir.
So, as a primary care physician, do you think that this creating awareness among patients will have a positive impact on the cancer screening and prevention?
Yes, sir. Sure, sir.
So, why that is not happening among staff then? They know, they know the seriousness of this issue, and still they are not reluctant to. They are reluctant to do. They are reluctant to get themselves tested. And so, what do you think?
From what I got based on the information collected was that the staff are having adequate knowledge regarding this cervical cancer screening. But what they told me was they wanted to wait till the symptoms to appear to get a test done, which means they are not very sure that it can happen even without symptoms also.
Yeah. So, would you like to reframe it as they are aware, but they are not fully aware?
Yes, sir.
Okay. So
The knowledge score was not like it was not very high among staff also, but comparatively it was better among the staff. That is what I wanted to say.
okay. So what will be your approach to educate as a primary care physician? What will be your approach to educate people? How which tool or how will you intervene if you are practicing in a remote area or as if you are working as a GP? How will you do that?
Sir, I want to educate each of the women attending my OPD, like whatever be the age group. I wanted to tell them something about cervical cancer screening so that at least they will spread the information they have got, and they will take the information to their home, and others will also get informed. Also, I would like to ensure that all the other healthcare workers like ANM, Sasha workers, Anganwadi workers, all are aware about this condition, and through them, the population is able to make use of such screening programs.
And one more question: from what age you should start giving this kind of knowledge transfer?
I think, sir, from schooling we can start to give, because cervical cancer being a preventable disease, we have now vaccinations also available to prevent these diseases. So even school children must be having some awareness about the preventive aspect of this condition, and mainly
Okay.
about the screening. You have to start from 21 years of age, ideally speaking, but the screening is mainly done on sexually active population at least after 1 year. So
Okay.
how to focus.
Okay. Thank you.
Thank you, sir.
Whether Dr. Hemant has joined. Hello, sir. Hello, sir. Whether Dr. Hemant has joined? Okay, Dr. Sirin and Dr. Preeti, we are moving with the second posture. I think meanwhile, Dr. Hemant will be joining. Thank you, Dr. Preeti. We will move to the second posture presentation. Dr. Bino will present it.
Good morning, everyone. Am I audible to everyone?
Yes, sir.
Okay. Good morning. I am Dr. Bino from Department of Family Medicine, final year postgraduate student from Christian Medical College, Vellore. I'll be presenting this poster. This is a 9-year-old girl child who's premorbidly well, who presented few months ago to our OPD with bilateral pitting pedal edema and colloquial urine, and on examination she was found to have elevated blood pressure. So our clinical diagnosis of glomerular nephritis was made in OPD, and she was suspected to have post-streptococcal. So relevant investigations were sent here. Complements were low, and her AS1, ADNB were abnormal, and she was started on diuretics, intravenous diuretics and calcium channel blockers. Her routine urine microscopy showed elevated WBCs, and with the background of fever, she was also initiated on injection ceftriaxone as empirical broad spectrum third generation cephalosporin. On day 4 of hospitalization, she developed anorexia and severe upper abdomen pain. Morely the pain is more in the right upper quadrant. So she did not respond to the usual symptomatic treatment with proton pump inhibitors. Emergency ultrasound abdomen was done, which showed a gallbladder calculi. However, the biliary tree was not dilated. So an emergency pediatric gastro opinion was obtained. So they were suggested that this could be due to antibiotic ceftriaxone-induced gallstones. So as per their advice, ceftriaxone was changed to cefotaxime, and her symptoms were resolved slowly, and within 48 hours, her symptoms were subsided. So we have done a follow-up ultrasound after 8 weeks of her index visit. So the ultrasound, as I mentioned in this picture, there was no residual calculi. So the mechanism of this is when we administer the injection ceftriaxone in any patient, for example, in a patient for a neonate or an adolescent, adult, or an elderly person. So the concentration of this drug is will be elevated at 20 to 150 times greater than in the gallbladder when it compares to serum concentration. So they can form a calcium ceftriaxone complex leading to gallbladder sludge, and further leading to the formation of gallbladder calculi. So in this particular child, the ultrasound findings, the timing of exposure to ceftriaxone therapy, the absence of risk factors, especially in this particular child, there was no family history of any gallstones. The child is not obese, and there was no history of any hemolytic anemia like sickle cell anemia or any hereditary spherocytosis. These findings and this clinical picture strongly suggest that these gallbladder stones were secondary to this antibiotic treatment. So to conclude, as primary care physicians, and we will be administering ceftriaxone for all the initial for the urinary tract infections or any respiratory infection. So we should be aware of its potential adverse effects, and if gallbladder calculi is detected incidentally, recent ceftriaxone therapy must be questioned, because there are literatures and there are incidences that children were taken up for surgery with this ceftriaxone induced gallstones. So that by knowing this, we can avoid this, and we should avoid giving ceftriaxone along with any other infusions. So most of these calculi will resolve spontaneously after discontinuation of drug. There is no specific treatment for this drug. Thank you so much.
Dr. Bino, nice presentation.
Yes,
Dr. Hemant. Dr. Bino.
yes, sir.
I'm a primary care physician, and how do you think that your paper is going to help me in a few sentences?
Sir, especially if a patient comes with acute onset and right upper quadrant pain, we will be looking for different etiologies, but along with those etiologies like alcoholism or any obesity or any hypercholesterolemia or any past history of gallstones or any family history of gallstones or cholecystectomy, we should also keep in mind that certain drugs like ceftriaxone and certain drugs like long-term intake of furosemide and octreotide, all those things can also develop a gallbladder sludge or gallbladder calculi. So making awareness, making these things clear, so we can also help the patient in the treatment regime, sir.
Yeah. So which part? So the would you frame it like the systematic way of taking a proper history?
Yes, sir.
Will help
Yes,
us,
sir.
right?
Yes, sir.
How frequent we get these ceftriaxone induced gallstones? How frequent?
So the literature says it's like 1 in like 10 in 10 out of 100, 1 out of 25 or 4 out of 100 will get these symptoms. There are very few literatures and among Indians studies there are very few, and most of them are in neonatal age group, because we'll administer for most of the infections in the neonatal period. So 1 out of 25 or 4 out of 100 is the usual thing, sir.
Yeah. How often we administer antibiotics? Any idea? Any guess? How often we give these cephalosporins and all? How often we give?
Sir, if you're admitting a patient like without any focus, fever without focus, suspecting fever, acute febrile illness for more than 5 days, or without any focus, we'll usually start empirical cephalosporins, predominantly with third generation cephalosporins, suspecting that this patient probably enteric or to cover the broad spectrum antibiotics. We'll give this antibiotics.
Yeah, I agree. Do you have any idea how often we administer to hospitalized patients this ceftriaxone and all? How often? Any rough idea regarding that?
That I'm not sure, sir.
Okay, no problem. Okay, thank you.
Thank you, sir.
Dr. Serin, Dr. Hemant will be joining us soon. We can move with the third posture. That is Dr. Melinda. We'll start with the third posture. I think Dr. Hemant.
Yeah, Dr. Hemant has joined.
He will start with the third posture. He might not have been there with the Dr. Bino's presentation. Okay, we'll move with the third presentation.
Good morning, everyone. Am I audible to everyone?
Yes,
Yes,
good morning,
sir.
Dr. Melinda. Good
Good
morning, everybody.
Good morning, everyone. Today, for this poster presentation, I have chosen an interesting case that I have come across during my family practice. It's about an uncommon presentation of a young hypertensive patient. Commonly, this is regarding a 41-year-old young unmarried lady who presented to family clinic of CMC Vellore. Detected to have an elevated blood pressure during one of her visits. Associated symptoms of shortness of breath or any signs or symptoms of fluid overload state. She did not have any dyspnea. She was not oliguric. She did not have chest pain or syncope, no blurring of vision or any other symptoms to suggest a possible target organ damage. She gave a history of aphthous ulceration in 2018. Apart from that, she is also a known schizophrenia patient and also a hypothyroid patient who's on regular medications for the same. She is a postgraduate in social work who's presently working as an NGO in Bangalore, and her hometown is Vellore, so she keeps visiting her hometown often, where she comes to our family medicine clinic for her regular follow-ups. On examination, her BP recordings were 170 by 100. And she was also found to have remarkable discrepancies in her right and left arm. Her heart rate was 100 per minute, and she was found to have all peripheral pulses palpable normally. Her body temperature was normal, and there were no other remarkable findings on any other systemic examination. On investigating her further, all her preliminary blood and urine investigations were normal, including her renal function tests that we usually do for all young hypertensive patients. And we further went on to evaluate her because her BP was not getting controlled. So we did a renal Doppler, and renal artery Doppler showed an acceleration time with increased acceleration time, which was increased, and also had a decreased RI levels in the right intraparenchymal vessels and increased velocity in the right renal, and left renal artery showed a mild decrease in RI values. We further went on to do a CT abdomen for her, and that showed wall thickening with significant luminal narrowing in the mid portion of the right renal artery. There was also wall thickening and mild narrowing in the left renal artery. There was another significant finding was there was diffuse wall thickening involving the abdominal aorta, but there was no significant calcification as such. We further went on to do evaluation of vasculitis, and that showed elevated inflammatory markers. Therefore, a provisional diagnosis of Takayasu's type 4 was made, and we went on to coordinate her care immediately with rheumatology, nephrology, and cardiology. And in rheumatology, patient was immediately started on oral steroids and MMF, and she underwent transfemoral, coronary, pulmonary, and peripheral angiogram, and a PTA to right renal artery. And post-stenting, we found that the right renal artery was patent, and presently patient is doing very well with collaborative care and comprehensive care under family medicine physicians and also specialists. So just a word to say about Takayasu's arthritis. We all know it's called a Pulseless Disease. It's a complex vascular disorder without a cure, which occurs commonly in young Asian women. And it's a systemic inflammatory condition leading to damage of medium and large arteries and their branches. And it's usually considered as a disease of the young, with most patients between the age group of 40 to 50 years of age. It's characterized mostly by inflammatory granulomatous vasculitis of medium and large arteries, leading to transmural fibrosis, thickening of arterial walls, and leading to multiple vascular obstructions, and eventually ischemic changes. The first presentation we usually see is non-specific constitutional symptoms such as fever, malaise, weight loss, anorexia. And other form of presentations may be hypertension, neurological manifestation, and upper limb claudication symptoms secondary to arterial insufficiency. And here we know that the diagnosis is usually based on suspicion that a family physician or a primary care physician will have during their OPD visits, and also arteriographic findings. And this arteriographic findings, it usually involves the aorta and major branches, particularly renal carotid arteries and subclavian arteries, leading to stenosis, occlusions, or aneurysmal degeneration of large arteries. And an abnormality noted in cell-mediated immunity seems to be the main pathogenesis behind this. And the treatment, as we all know, is usually medical management, corticosteroids, and also immunosuppressive medications added on. But however, we know that surgical management has become more common recently due to the findings of overall lack of disease regression with high rates of relapse with only medical management alone. And here I like to conclude my slide by saying that prompt diagnosis, which we do in primary care and in family medicine centers, seems to be very important in managing these patients and also preventing them from any complications that can arise because of this condition. And this we can see that how it was been best managed with an interprofessional team in the above scenario. And these patients, we also have seen that they need long-term monitoring and follow-up, especially regarding side effects of these drugs, which can be done by family care providers and also family practitioners in practice. Thank you.
Thank you, Dr. Melinda. It was a very nice effort to present a case of such relevance. What is the prevalence or incidence of Takayasu disease, arthritis in the world?
We say about 40 to 55 cases in about per million of persons. That's what, according to the...
It is 2.6 per million.
Incidence.
It is 2.6 per million. Okay, our numbers are slightly different.
Okay. These are Western studies. Okay.
Secondly, you very rightly said there's a difference in the pulse in both hands. So, what are the other causes of difference in the pulse?
Pardon, sir, can I get your question?
You mentioned that during the examination, there was difference in the pulse in both hands. That is how you actually come to the get an idea that there might be something underlying, and probably that is how you proceeded. No,
there was a difference in the blood pressure, sir, not the pulse.
Okay. Otherwise, so what was the difference in the? What was the nature of the difference?
It was more than 20 millimeters of systolic blood pressure.
Okay. Actually, it is called pulseless disease. Why is it called pulseless disease?
Because it affects the medium and large arteries. Sometimes you will not be able to feel the radial pulse or the brachial pulse if it involves a subclavian artery.
In this case, you could feel the pulse?
Yes, the pulse was felt, sir.
Okay. So what are the other causes of difference in pulse? Did you consider them? Because this is a rather rare disease. It is a wonderful presentation. You have managed it, diagnosed it in your center because it is a tertiary center. So family practices are actually community-based. They are usually most of them are standalone practices. So you think a person who should, there's a difference in the pressure and there's a feeble pulse with a history of hypertension or diabetes, and this patient doesn't have diabetes, but usually it is also associated, one of the causes is also diabetic neuropathy, then atherosclerosis and heart disease. So you think one has to diagnose all these things? Is it, how relevant is this case to family practice, in your opinion? Because you are in CMC, it is a tertiary center. So you could diagnose it, and you've diagnosed it well. Hello?
So
yes, sir.
You will get 2 more grace minutes, sir. After that, the posture will be changed.
Okay, okay.
Thank
you. So, Dr. Melinda?
Yes, sir. So not able to hear you very clearly, sir.
I said, you've diagnosed it very well, but you think, is it relevant in your opinion to the family practice, this case?
Yes, sir. Though it is a rare condition, I think we should not miss even one patient who has high blood pressure, especially a young patient who we might think it's a part of an early essential hypertension. So the patients who present to us between age group of maybe 35 to 45 years with a high BP recording, I think they should be evaluated for any possible vasculitis, which we can miss if we do not think of these diagnoses at the back. So at least, so this patient actually, we had done all the preliminary investigations which were normal. So even after doing that, and if we find that the BP is not getting control with our antihypertensives, we have to do a renal artery Doppler to rule out.
No, I
any
understand.
possible.
Thank you. Thank you very much.
Yes.
Thank you.
Thank you, sir.
Thank you, Dr. Melinda. Thank you, Dr. Hemant Saluja. We will move with the fourth presentation. Dr. Ashwati will take it up. Sorry for interrupting. Meanwhile, I'll just make that an announcement that each presenter will get 8 minutes to present. And after 8 minutes, a bell will be rang, following which 2 more minutes of grace period can be awarded. And after 10 minutes, the slides will be changed. Please stick up on the time. Thank you.
Good morning, everyone. I'm Dr. Ashwati from Lutz Hospital, and I'm presenting a poster on our hospital-based observational study on the perceptions and practices among mothers of children with febrile seizure. Febrile seizure is the commonest cause of seizure under the age of 5 years, and it's frightening to parents and caregivers, and it gives rise to parental anxiety and apprehension. Aim was to study the perceptions and practices among mothers of children with febrile seizure in a tertiary care hospital. Objectives were to determine the maternal perceptions regarding febrile seizure and to assess the practice followed by mothers of children with febrile seizure. Materials and methods. After obtaining informed consent, a pre-tested, semi-structured questionnaire was administered to mothers. Sample size of my study was 60. Mothers who got more than 80% answers correctly were considered to have excellent perception. Those who had 50 to 80% answers correctly were considered to have good perception. And those who got less than 50% answers correct were considered to have poor perception. A mother was considered to be following correct practice if she was able to answer all answers correctly. If one or more questions were answered incorrectly, mother was considered to be following incorrect practice. Now coming to the results and evaluation. Majority of children belong to the age group of 1 to 2 years, followed by 2 to 3 years. Age group 6 months to 1 year had least number of children. More than 80% of children were female. About 2/3 of children were firstborn. Here the bar diagram shows the distribution of education and occupation of mother. Majority of mothers had graduate or postgraduate education and majority had semi-professional occupation. Doctors were the chief source of information, followed by staff nurse, internet, family, and friends. 95% of the episodes of febrile seizures occurred at home, while 5% occurred in daycare. 68.3% of mothers had poor perception about febrile seizure. 31.7% of mothers had good perception, while none of the mother had excellent perception about febrile seizure. 98.3% of mothers followed incorrect practice, while only 1.7% of mothers followed correct practice. And there is no significant association between perceptions or practices with education or occupation or number of episodes of febrile seizure. My recommendations are: primary care physician has to address the stigma towards febrile seizure and also educate the children regarding correct knowledge and practice. Mothers should be educated regarding febrile seizure, and correct practice regarding the febrile seizure and has to be reinforced in mothers, which in turn will reduce the number of episodes and in turn will reduce the number of hospital admissions. Thank you.
Very nice presentation, Dr. Ashwati.
Thank you, sir.
It is a very, very relevant topic to family practice. And you have displayed the poster very well.
Thank you, sir.
Now, can you tell what was the developmental profile of these children who had? Or did you account for the developmental profile of these children who had febrile seizures?
No, my sample size included children with normal neurodevelopment.
Wonderful. So the point I wanted to convey was febrile seizures happen in children with normal development. Development is not affected if it is a febrile seizure.
Yes.
So you have brought out the points well. And what methodology other than the questionnaire did you use to come to the conclusion of your poster, of your study?
It's a cross-sectional analysis. After giving the semi-structured questionnaire, I analyzed the data.
And this was done by a single investigator or by multiple investigators?
Only I was the single investigator.
So we rule out
Yes.
investigator bias also. So
Yes.
inter-investigator bias.
Yes.
Good. And this was explained in the language of the patient?
In the language of the patient. After giving the questionnaire, I gave a brief introduction, and then I asked them to fill out the forms, and then I analyzed the data. And after obtaining my results, finally, once I see the patient in the pediatric ward with febrile seizure, then I explain to them more about the disease and the disease and the prognosis of the disease, and I try to explain hear their concerns more than I used to do before.
And could you follow up them with whatever knowledge or information you gave? Did they fare better in their practices of managing?
In these children, I was not able to follow, but once they came for recurrent admission, I was able to meet
I
them.
understand it is beyond the scope of this study, but did you, by happen chance?
No, only by chance, if they get admitted again and if they see them again, then I was able to talk to them. But as just like that, I was not able to follow them.
Okay. So in your entire exercise, what was your learning? What was your learning?
It was that mothers had poor perception about febrile seizure, and most of them followed the incorrect practice about febrile seizure. So they needed to be educated about the febrile seizure. They need to be educated regarding the profile and the prognosis, and about the medications, and about the correct practice that they can do at home, because they can do at home once there is a febrile seizure, and also prevent febrile seizure.
Because your study clearly points out that the firstborn female child perhaps would be the most liable or most likely to have, because you said it female preponderance and firstborn preponderance.
Firstborn was more predominant, but I
Now,
did not.
when you say firstborn, I hope you have taken families in which there are more than one offsprings.
Yes, sir. Yes, sir.
All families that you took were having more than one offsprings?
No. Some were just first child, like single child, and they were definitely firstborn. So.
Okay. Thank you very much.
Thank you, sir.
Actually, I have one question. Why there is a huge disparity in sex distribution of children? Do you have any explanation for that?
I don't have an explanation. I thought it will be significant, but did not get any significance after analysis. And then it may be also because male children are given more importance, and they are taken to hospital immediately in case of febrile seizure. It can be that, and maybe females are managed more at home after the episodes.
Could be that girls are more in Kerala?
No, it's less. Yeah, girls are more in Femina, but in my study, more male child are more affected. So.
Yeah, that is what I wanted to ask. In Kerala is one of the state with having male-female sex ratio more than one. So ideally, we should get a. If you are taking a random sample, then naturally the proportion of male child should be more than female, right?
Yes, sir. Yes, sir. In my study, I did not get any significant feature, but maybe it's just an incidental finding. But
okay.
Thank you, Dr. Navina. Thank you, chairpersons. We will move away with the next presentation. I would request Dr. Navina to start up with your posture.
Good morning. Sir, am I audible?
Yes, loud and clear. Good morning.
Good morning. I'm Dr. Navina Prince Shandy, DNB resident at Department of Family Medicine at Lutz Hospital, Ernakulam. I'm going to present a poster on the topic, the spectrum of dermatological problems seen in family practice, a case series. The guides for my poster were Dr. Kriti Deviraj Ulal and Dr. Reshmi S. Kaiman. As a primary care physician, skin problems constitute 12.4% of all the cases that we encounter every day. So in my poster, I would like to highlight 6 cases among the many that came to our family practice center in my 3 months posting, which is situated 10 kilometers away from the main hospital in the island of Whitefield. So my first case was a 25-year-old lady. She came with a bluish discoloration of the face. It was increasing in size. And on probing the history, we got the history of use of fairness cosmetic. So the patient was asked to stop the use of cosmetic immediately, and she was referred to a dermatologist for laser therapy. Second case was a 45-year-old lady. She came with a red, painful coin-shaped patch on the scalp. On examination, well-defined annular erythematous plaque was seen on the scalp. The patient was referred to a dermatologist, and she performed a skin biopsy, which confirmed the diagnosis of discoid lupus erythematosus. And we followed up with the dermatologist, and she advised topical corticosteroid. And the lesions actually reduced in size after some months. Then case number 3 was a 35-year-old female. She came with a rash over the abdomen with itching. On examination, brownish red scaly pruritic papules was seen. The diagnosis was made clinically based upon the skin lesion, and the case was discussed with the dermatologist. And she gave topical antifungals, and we followed up the patient in our OPD only. Case number 4 was a 30-year-old female. She was a migrant laborer from North India, and she came with some erythematous nodules over both upper extremities. There was fever and malaise. The ulnar nerve was thickened on both the arms. We had a clinical suspicion of leprosy. So we consulted the dermatologist, and skin biopsy was done from these nodules. And skin biopsy actually confirmed the diagnosis as erythema nodosa leprosa. So we sent the patient to the nearest district hospital for further management. Case number 5 was a 8-year-old boy with patchy hair loss over the scalp. So in the history, we got that the child was having the urge to pull the hair out. So counseling was given for the patient, and actually the child came back with reduced lesions. Case number 6 was the patient who came with yellow discoloration and thickening of nails of all the fingers. So the lady gave the history of use of several steroid creams. Clinical diagnosis was made as onychomycosis, and antifungal itraconazole was started. We followed the case in family medicine OPD only. The lesions took time, but it resolved over a period of 6 months. The conclusion of my study is that prompt management, timely referral, and coordinated care are the keys to managing dermatological problems in family practice. This emphasizes the need for dermatological posting during the postgraduate training period of family medicine. So I would like to conclude by saying that my take-home message: a general practitioner should acquire the skills and knowledge to deal with this vast spectrum of dermatological problems. Thank you.
Thank you, Dr. Navina.
Yes, sir.
It was a very wonderful, lucid presentation on a very relevant topic.
Thank you, sir.
Dr. Serin. Dr. Serin, you want to ask something?
Navina, nice presentation.
Thank you, sir.
I have a few doubts actually. How often you get dermatological cases in your OPD? To be precise, during your peripheral posting, how often you get dermatological cases?
Sir, I myself have done a study on dermatological problems. It was in a pediatric age group, but I got as high as 36% in my hospital. So I have referred to the literature in South Indian population. There are no much studies in our Indian population, but there is a study in Egypt, and that is high as 50%, 36 to 50%. So I think as a family practitioner, we are bound to have cases with skin problems in our OPD. So this is
No, my question is precise.
in our hospital.
How often you get?
Sir,
When you were in peripheral posting, how often you?
36%. 36% was the one which I have done a study on, and I have found that it's 36%. It's very common, I think.
And how often you have to refer to a dermatological for further management?
90% of the patients we could manage ourselves. Even in this, I have shown that most of the patients we could ourselves manage. Only very few cases we had to send directly, especially the erythematous leprosa, we had to send for skin biopsy. Other than that, all the patients we could do ourselves, or at least discuss with the dermatologist and then deal. We didn't have to send all the patients. Only very few patients. Maybe
How often you take opinion from your dermatologist?
So whenever diagnosis is in doubt, we usually.
No, that is if you get 10 cases in a day, how out of 10?
2 cases.
How many
2 cases.
2 cases. Okay. And you have followed up all these cases, right?
Definitely, sir.
Are they happy? Are they happy with your management?
The only patient who was little bit disappointed was a DLE, but we had already discussed that disease is difficult to be controlled and would require a longer longer term management. And she was a little bit disappointed, but all the others were really happy, especially the ENL patient. She had gone to so many people and without a diagnosis. So we could pick up a leprosy patient. Actually, we were not expecting ENL in our area.
Dr. Navina, how long you think is the treatment of onychomycosis?
Sir, actually, for nail infection, it will take about 6 weeks. And for toe nail infection, it will take about 12 weeks.
So in your 3 months of posting, you in what, how down the posting did you come across this case? Because 6 weeks of treatment and then follow-up, probably your posting would have lapsed without follow-up, in my opinion.
Sir, actually, this patient came in the initial days only.
Okay.
So we could, but whenever leaving the posting also, the lesions were not fully resolved. But we had told that lady that it will take time.
That is, and the lady with tinea imbricata?
That also took some time to resolve. The patient was followed up, but lesions were decreasing in size, but it was not completely.
Yeah, because it takes a little while for these lesions to heal, actually.
Yeah, the patient was happy because there was some progress. The itching had reduced and it was not concerning for her. So she was happy. But...
Thank you.
Thank you, Dr. Navina.
Thank you, sir.
Thank you, Dr. Navina, judges. We will move with the 6th presentation. Dr. Days will present her poster.
Good morning, sir.
Good morning.
Good morning, sir. I'm Dr. Days Maria Babu from Lutz Hospital. I'm presenting a case report about an alcohol intoxication and seizure. My co-authors are Dr. Somesh Chako, who is a consultant physician from Lutz Hospital, and Dr. Rashmi Kaimal, who is a consultant and head of the department Family Medicine, Lutz Hospital. My patient is a 58-year-old male who is a chronic alcoholic since last 30 years. His last binge, as per bystanders, was 2 days back. He was referred from a periphery hospital by a family physician with a history of generalized tiredness, headache, and loose stool for last 2 days, and one episode of witnessed generalized tonic-clonic seizure at home. On examination, he was received in our emergency department, and on a clinical examination was found that he has a poor GCS of 4 out of 15, and the pupils were bilaterally dilated with sluggish reaction. He had tachypnea, tachycardia, low blood pressure with cold, clammy extremities. His GRBs on the time of examinations was 125 milligram per deciliter. On systemic examination, central nervous system, GCS was poor. Tone was decreased in all limbs. Bilateral plantar was mute. Dependent reflex showed no response, and all other systems, other than hypotension and in shock, other systems were within normal limits. On evaluation from the emergency department, an emergency ABG was taken, and which showed that there was a severe metabolic acidosis. His pH was about 6.92. Bicarbonate was less than 3. Potassium values was 4.1, and the oxygen and carbon dioxide values were normal. It was found that there is a high anion gap metabolic acidosis at the time of evaluation, and the routine investigations were done in view of the very severe metabolic acidosis and very low GCS. The patient was intubated and ventilated from the emergency department. And on primary evaluation, the blood investigation showed that hemoglobin was 11. Liver transaminases were elevated. Amylase and lipase was also elevated, and the blood lactate level was found to be 35.6, which was very high. The other blood investigations were normal initially. This patient was intubated and ventilated, and since there was a high anion gap metabolic acidosis, we thought of a possible methanol poisoning, and the patient was started on IV dextrose. As a patient was having hypotension and in shock, a patient was started upon inotropic support and given IV antibiotics. On day 2, the general condition of the patient remains set and deteriorated. The BP was maintained only on inotropic support. We could not wean off the ventilator support. IV dextrose and was continued, and in addition, he had frequent hypoglycemia, for which 25% dextrose was given. Then by day 2, the CT brain was taken. The CT brain, since we had a suspicion of a methanol poisoning, we took a CT brain which showed bilateral putaminal hemorrhage with necrosis, and which almost confirmed our diagnosis. The toxicology samples were sent on day 2 for estimating the serum osmolality and methanol estimation. But since the day was after second day, the methanol was found to be very low. We could not come to a conclusion that is a methanol poisoning. By day 3, the condition deteriorated, and the patient was started on hemodialysis from day 2 onwards, even on inotropic support. And by day 4, he continued to have his condition deteriorated after HT, and the pH value by day 4 becomes 7.234, and the bicarbonate get improved only up to 9, and the patient had a sudden cardiac arrest, cardiac failure, and respiratory arrest, and the patient expired on day. So the discussion part is that although we have provisional diagnosis of a methanol poisoning, we could not conclude it properly with methanol estimation. So my discussion is a methanol exposure can cause a varying degrees of toxicity and may require a range of treatment depending upon the stage of poisoning and the stage of presentation of the patient. The management consists of a supportive care, flumeprazole, ethanol, and hemodialysis. The DDs for the methanol poisoning is salicylate, acetaminophen poisoning, and alcohol ketoacidosis. Since my conclusions are this alcohol intoxication and withdrawal seizures are frequent in our general practice, but all seizures may not be the same. There can be methanol poisoning. A proper analysis of the primary investigation, including an ABG, help us to come to a conclusion that whether it is an alcohol intoxication and that alcohol withdrawal seizures or a methanol poisoning. These are my references.
Thank you, Dr. Daisy.
Thank you.
Your patient came with an attendant, or he was brought by unknown people?
He was brought by a bystander, sir.
So you could not have established whether he is a diabetic or was on any medication, because there are other causes of metabolic acidosis.
This patient, as per the bystander, he did not have any other comorbidities other than chronic alcohol intoxication. This history was given by his wife herself.
Okay, so the subsequently upon admission, reliable caregivers had arrived.
Yes, sir.
Okay. How was his liver function?
His initially it was only 67/23, and later it was not repeated because
with a pH of 6.9, what is the prognosis first that comes to your mind?
Very bad prognosis, sir. Very severe metabolic acidosis, and we have already from the day one itself, worst prognosis was explained to the bystander because the pH was very low and there is impending cardiac respiratory failure. Was explained to the bystander on day one itself, sir.
And have you heard of other causes which cause similar presentation?
Salicylate poisoning can be a differential diagnosis. Then alcohol withdrawal seizures are the usual presentation in our casualty. But it could be managed, and this ABG showing severe metabolic acidosis with high anion gap gave us a clue to that possibility of a methanol poisoning is present.
Dr. Daisy, it is very nice presentation, but the issue is that how relevant it is to see you. One really has to see from a holistic point of view that family practices are standalone practices. Not everyone has the opportunity to practice in hospitals like Lord's, and it is not a specialty that is required for hospital-based practice.
Okay,
so ABGs are usually, in my opinion and experience, not usually done by family physicians. Isn't it, Dr. Seren? So for ABGs, we don't actually do it, but it is a very nice and challenging case. And have you heard of the condition called MELAS, MELAS?
Yes, sir.
It is one of the causes of metabolic acidosis that presents like mitochondrial encephalopathy and lactic acidosis and stroke-like symptom. It is a very rare condition. Happens only between the in younger age group, 2 to 15. But your case is very challenging, but I think the investigations befits your level of where you are practicing. But I think it is not for one has to keep in mind that 6.9 pH has very bad prognosis, and there are other causes. It was a very well investigated, very well cared for case. No doubt about that. Very well presented. Thank you.
Thank you, sir.
Dr. Dace,
Yes, sir.
I have a question.
Yes.
Suppose you are sitting in one of your peripheral institutions and this patient is being brought to you. So how will you manage? Means, how will you assess? How will you stabilize her?
First, the patient was having a shock. Patient was brought here with a shock. So we can, since there is a history of alcohol intake 2 days back, possibility of a withdrawal seizure have to be keep in mind, and we should start with IV dextrose with thiamine Then since he's hemodynamically unstable, we have to rush with IV fluids. And if there is possible, we have to start on inotropic support initially. But since in our peripheries, ABG is not usually available, so it is better to do an ABG, but it is not available. And we can give, if that is IV lorazepam, long dose benzodiazepines.
What all you assess if you are sitting in periphery, you don't have access to all these investigations and ABG
Okay.
and all. So what all will you assess if you are sitting and if you are
we have
sitting
to
in-
assess the GCS levels. Pupils have to be looked for. Then the vitals, we have to look for any shock, possibility of a circulatory or then respiratory failure, we have to assess. Then keeping in mind there is a chance for head injury, we have to assess for any history of, we have to get the history regarding any history of any fall or not. Then other systems, CNS have to be evaluated. Then possibility of any GA bleed underlying.
Okay, thank you.
Thanks.
Thank you, Dr. Days. Thank you, judges. We will move with the next presentation. Dr. Bushra will be presenting her poster.
Good morning, everyone. Am I audible?
Yeah, loud and clear, Dr. Bushra.
Okay, thank you, sir. Myself, Dr. Bushra Tasneem, DNB resident, Family Medicine, Lourdes Hospital, Kochi, and I'm presenting the case of 58-year-old male shopkeeper who presented with sudden onset high-grade intermittent fever associated with chills and rigor, fatigability persisting since 2 weeks in spite of treatment from local hospital. There was history of contact with pets, mainly goat and poultry. On examination, patient was conscious, oriented, sick-looking, febrile, pulse rate 100 per minute, BP 200 by 100 millimeter mercury, and temperature was 102 degree Fahrenheit. All other general and systemic examination was within normal limit. Now move on to the clinical course. On evaluation, ESR, CRP, RBS, TSH were high. Blood culture was sent on the first day before initiating the treatment. Echo was done and was normal. He was provisionally diagnosed as a case of pyrexia under evaluation with newly detected diabetes, hypertension, and subclinical hypothyroidism. Treatment started with broad-spectrum antibiotic, insulin, thyroxine, and amlodipine. Cefoperazone sulbactam was the antibiotic started. On second day of admission, fever spikes persisted. USG abdomen was done and showed splenomegaly with multiple cysts. Discussed with the radiologist and possibility of microabscess explained. IgM dengue was positive, but it was ruled out as the pattern of fever was highly inconsistent to the one in dengue positive patient. On third day, fever spikes persisting. Total count platelets started to fall. Vidal became positive. Discussed with the microbiologist. Possibility of salmonella ruled out since they got gram-negative oxidase positive bacilli. Hence, waited for the culture and sensitivity report. Culture report came on the day 5 and showed heavy growth of Burkholderia pseudomallei, diagnosed as a case of melioidosis, which was resistant to cefoperazone sulbactam. Antibiotic changed to ceftazidime. Patient became symptomatically better, and there was no fever spikes for the next 4 days. But on the day 10, patient started to develop fever again. On examination of chest, there was crackles in right infrascapular region. Chest X-ray was repeated and showed bilateral lower zone haziness. Total count was high. HRCT thorax with abdomen done and discussed with radiologist. Findings were consistent with melioidosis and injection meropenem was added. Next day, patient developed icterus and LFT was deranged, but repeated UST showed no signs of disease progression. Patient improved symptomatically, no fever spikes thereafter. And patient was discharged after completing 7 days of meropenem and 7 days of ceftazidime with the advice to continue injection meropenem for 1 more week and tap doxycycline for 6 months to prevent the relapse. Now, the patient is on regular follow-up in our OPD and 5 months of treatment completed, asymptomatic and back to normal life. Retrospective history reveals swimming through floodwater in July 2018. After 4 months, patient developed cough and fever for 1 month duration. He was seen in our OPD. TB was ruled out at that time, and he was treated as a case of pneumonia. Take home message from this case: as a family physician, fever is a common symptom we encounter on a day-to-day basis. There should be high clinical suspicion in case of fever of long duration. This case shows the importance of systematic approach to diagnosis and treatment. Otherwise, we could have misdiagnosed as a case of dengue or typhoid instead of the real culprit. Multidisciplinary approach involving microbiology, radiology helped to end the wild goose chase. Thank you.
Wonderful, Dr. Bushra. Thank you. But can I ask you more about the fever?
Yeah, so it was sudden in onset, high grade, intermittent, and
Hmm.
associated with chills and rigor.
And how many days?
Yeah, the patient complaints came with the complaints of 1 month duration of 2 weeks duration of fever, and 1 or 2 spikes per day, and no diurnal variation.
When you are having 2 spikes, so what diurnal variation are you looking at for?
Yeah, the spikes maybe in day or night, no diurnal variation, no particular timing for the spikes.
Okay. In 4 weeks or 2 weeks duration, do you expect IgM dengue to be positive or IgG dengue to be positive?
Yeah.
And for Vidal interpretation, you have to have a baseline Vidal for any baseline comparison of rise in titer. There is a single diagnosis method also, but basically we are looking for a rise in titer.
Okay.
And this case you studied in 2020 or 21?
21. Sir.
So is the swimming through flooded waters 3 years ago relevant?
Yes, sir. Because melioidosis can be indolent fashion and may recur after 3 years.
Okay. What is the other name of melioidosis? Whitmore's disease.
Yeah.
And it is basically found in people who are taking care of farm animals, like where people engaged very closely with the soil actually. So all farmers, all countries, people living in the countryside, basically very close contact with the farm and nature. So it was first found in Australia, and I do not think that it is an endemic. So did you report it? And did you publish it somewhere?
Not till, sir. Not published till, sir. We are planning to publish it.
So as Dr. Sarin rightly asked the previous contestant that if you were to see a patient of 1 month or 2 weeks duration fever in standalone family practice, what would be your approach?
Yes, sir. We should have a high clinical suspicion because
Of what?
Rare causes also. And in this scenario, in Kerala, we are coming across floods more common. And in India also, melioidosis is an emerging disease. More cases are reporting from the coastal regions and all. But unavailability of the microbiological support, these cases goes unreported.
Ma'am, my question is, if you were to practicing in a remote setting and patient came with 2 weeks fever, what would you do? How would you approach?
Yeah, we should look for the common causes.
Yes, exactly. Common things are first. And very rightly in your treatment, in your investigation protocol, you have arrived at, you have actually diagnosed all the positive things. So dengue is also positive and Vidal is also positive. So you think what made you not do the platelet count?
Yeah, we have done the platelet count, and initially it was normal, and after 2 to 3 days, it became falling.
So actually in dengue, if the fever is of 2 weeks duration, you don't see platelet count after 2 weeks. No, you see it much before that. So was it relevant? Was it fitting the clinical picture?
No, that's why
That is exactly the point I'm trying to bring home. In a remote setting, if you see things, clinical picture not matching the laboratory, think of something else.
Okay.
Well done. Thank you.
Thank you, sir.
Yes, Dr. Serin, is there anything you want to ask Dr. Bushra?
Yeah, I would like to ask some questions. So my question is very simple. What do you think? What made the patient to come for follow-up after getting so many? I mean, the patient was on so many, almost the patient was on almost all antibiotics, I think, right, Dr. Bushra?
Yeah, he was started with cephalosporin sulbactam, and after cultural sensitivity, we changed ceftazidime, and though the fever spikes persisted, we added meropenem.
Yeah.
And on discharge, we give injection meropenem for 1 more week and tap doxycycline for 6 months.
And the patient was treated by the family physician, right?
Yes, sir.
So what made the patient to follow up with the family physician, even being treated at the tertiary care hospital, that too in Cochin? So what made? So what is the take-home message you can tell about? Though this can be a rare disease, but you could pick it up. But what made the patient to come for follow-up rather than going and doing doctor shopping?
Yeah.
He might have visited so many, even before coming there also, he might have visited so many doctors, might have consulted with so many specialists and all, right?
Yes.
Yeah. So what made the patient to stick with your family physician?
Yeah, he became symptomatically better, and he was explained the lethal effect of this disease, and also to follow up otherwise it will recur if he didn't follow up well.
If you try to frighten some patient, if you try to frighten a patient, no, especially in Ernakulam, the patient will definitely go to some other hospital, and he will be going after super specialists and all. This didn't happen in this case. Why?
Yeah, the communication is very important.
What communication is important? What communication is important? As a family physician, what communication is important? No, you have managed the patient. I'm just asking. Just want to know that. So you have managed it and you have presented it very well. So
Personal centric care.
yes. Thank you.
Okay, thanks.
Thank you, Dr. Bushra. Thank you, judges. We will move with the last posture before inauguration. That is Dr. Anuna will present a posture.
Am I audible?
Yes, ma'am.
Good morning, all. I'm here to present the topic is Profile of Acute Respiratory Infection in Children aged 1 year to 5 years in a tertiary care hospital in Kerala. Acute respiratory infections are the single greatest cause of death among children throughout the world. even though Kerala accounts for around 2.7%.
Dr. Aruna, I'm sorry to interrupt, but I cannot hear you.
Ma'am, can it be little louder?
Okay.
Otherwise, you can try without headphone or Bluetooth.
Can you hear me now?
Yes,
Yes,
sir.
much better, much better.
Okay, thank you so much. Sorry for the confusion. Yeah, so I'm here to present a topic on the profile of acute respiratory infection in children aged 1 year to 5 years in a tertiary care hospital in Kerala. Myself, Dr. Anuna Vinod, I'm a DNB resident in Family Medicine Department in Lourdes Hospital, Kochi. And my guide is Dr. Rashmi Kaimal, the head of department at Family Medicine, Lourdes Hospital, Kochi. So acute respiratory infections are the single greatest cause of death among children throughout the world. Even though Kerala accounts for only 2.7% of India's population, 17.5% of the total cases of ARI reported in India during 2014 were from Kerala. However, surveys for finding out the prevalence and various factors associated with ARI are very few, especially in the urban areas. So the aim of my study was to study the acute respiratory infection in children aged 1 year to 5 years in a tertiary care hospital. The objectives were to determine the frequency of acute respiratory infection in the last 1 year in children aged 1 year to 5 years attending the clinic at Lourdes Hospital, and to assess few selected epidemiological, socio-demographic, nutritional, and immunization factors associated with ARI in the study group. The methodology is as follows. It was a cross-sectional study with a sample size of 100. The sample population, as I mentioned, is 1 to 5 years attending the immunization clinic of Lourdes. Then I had given them a predestined and a pre-tested questionnaire, which was validated, and the data analysis was done by simple proportions and chi-square test. The results of my study are, in our study, of the total 100 study subjects who participated, 52% were males and 48% females. The proportion of children with ARI was 60%, which was higher compared to other studies in the same age group. Mother was the caregiver in 67% of the cases. However, in 66.67% of children with ARI, the caregiver was not their mother. The majority of mothers in the study group had at least secondary education. Among those mothers who had no formal education, 100% of the children got ARI. The occurrence of ARI was more frequent in rural compared to urban areas, though I couldn't get a statistical significance for that. The proportion of children with ARI was more, as is evident from the diagram, when there was a history of respiratory infection among family members, that is parents and siblings, compared to those with no such history. Then there is a significant proportion of ARI in non-exclusively breastfed infants compared to those who were exclusively breastfed. The proportions are shown. Children who were bottle-fed showed a higher occurrence of ARI, that is 66.23%, compared to non-bottle-fed babies, 39.13%. Children with a history of exposure to cigarette smoke, that is 73.17%, developed ARI compared to non-exposure to cigarette smoke. Children who were not immunized with the pneumococcal vaccine showed a higher occurrence of ARI compared to the immunized ones. The reference of my study, the parent study being Vijay B. Dilmonte and Johnson LR conducted a study named Prevalence of Acute Respiratory Infection Among Under 5 Children in a rural area of Kozhikode district, Kerala. The international journal, it was published in the International Journal of Community Medicine and Public Health in 2019 May. The recommendations would be, health education can change the healthcare seeking behavior of the patient. Now we have to focus more on immunization, as I've written in the statistics of pneumococcal vaccine here. And the role of family physician would be to bridge or reduce the patient-doctor gap. Then, as is evident, I've mentioned that there are no much studies in the urban areas, so we should include more studies in the urban areas. Thank you.
Thank you, Dr. Aruna.
Thank you, sir.
What was the, it was a very well presented, very clear poster, but what was the need of this study?
The need being that there is no much studies. When I looked up the data, there were no much studies in the urban areas, especially one coming from the south state of India. Accounting to the ARI that is present in India, Kerala is actually a little less way down.
maybe that's the reason, because we have more ARIs, and the deaths, mortality related to the deaths are more in the northern parts of India. So we don't really have many studies in the southern state of India. So I wanted a study which was in the southern parts of India and also in the urban setup specifically. Also, I was trying to derive a relation between the immunization, the status of immunization with the occurrence of ARI. I couldn't get a significant p-value or a significant data in terms of that, but I did get a positive response I had seen.
What was the time frame in which you conducted the study?
1.5 years, sir. 1.5 years.
Starting when?
2019 I started, sir.
And ended in?
2019 December I started, and it was 1.5, so 21 May or so, sir.
So the children in your 1 to 5 age group who lived through the pandemic, how did their parents ensure vaccination? Because in the initial 2020, the entire world was crying about child immunization taking the backseat.
So probably that is the reason I had a good proportion of people who were not vaccinated, especially the pneumococcal vaccine, which wasn't included then in the schedule. But being a private hospital, so pardon my voice, but being a private hospital, we were giving it as an optional vaccine so that they could take it. So ideally, when I inquired with, the proportion of people who were taking the vaccine was much higher. But in my study, actually, I did get a good proportion of people who have not vaccinated. And that's how I compared, sir. Otherwise, the proportion with vaccination, with no vaccination, was very less.
And Dr. Aruna, you are a family medicine resident, no?
Right, sir.
So you think it is a specialty that is to be practiced in tertiary hospital or in the community setting?
Community setting, sir, definitely.
Okay, good. And so what would you do in a community setting to ensure that the people under your care, their families and their under fives are have minimal ARIs? Because some amount of ARIs are expected in children. That is how they develop immunity.
Right, sir. So, so the etiology of ARI could be broadly like the agent factors, host factors, and the environmental factors. Here, as family physician, we might not be able to do much with the agent factors, even though, yes, sanitation and promoting good hygienic practices can help in eradicating them to a little bit. Sorry, sir?
Good hygiene practices like?
So good sanitation, sir. Good sanitation, good cough hygiene measures, because that's how it spreads, especially in the daycare setup and in the Anganwadis and school settings.
Can you enumerate the hygiene practices?
So I would like to start with good hand hygiene. The next would be using proper cough hygiene measures, using a proper handkerchief, and practicing safe distance when you have a particular disease, and not sending the kids to the school when they suffer from an upper respiratory infection, notifying the school when they have the same, and making sure that they don't mingle with the other kids. Those would be the basics.
Wonderful. And the most important is personal hygiene. You must tell the families to make it a family ritual to brush the teeth at night also. In the morning, everybody does it, but if you tell them to brush the teeth at night, you will see in your practice that the rate of upper respiratory infection comes down remarkably.
Okay, sir. Okay, sir.
So as a family physician, you must ensure compliance to good hygiene, better care, as you have already highlighted in your study. Dr. Serin, is there anything you want to ask?
Yeah, I have one question. Dr. Anuna, you are in your presentation, no? How protective is breastfeeding? I mean, till what age the protective effects of breastfeeding can be seen?
exclusive breastfeeding is very important for for a period of 6 months, and I have a very strong, like I've got a statistical significance of that as well. Also, another value which I haven't included is that if you start the complementary feeding before 4 months, most of them start with 6 months, but there is a tendency for the people to start at the span of 4 months itself. Most of them somehow are tamed into believing that it's okay to start at 4 months. So when I compared that, that is, if the complementary feeding was started before 4 months, or just at the brim of 6 months, I got a statistical significance that those who were started before 4 months had increased incidence of ARI, around 15% difference there in the two data. So it's actually very much important that
till what age this protective effect will remain?
Effectively, it is there for 6 months, which cannot be denied. But further, the breastfeeding can be continued for up to 1.5 to 2 years of age, sir.
Okay.
Along with other proper complementary feeding. They have to have the normal feeds by the age of 1 year.
Okay. And if from your background, 17% of the cases reported in India are from Kerala. Why is so? In Kerala, we have a good practice of vaccination, hand hygiene, respiratory hygiene, compared to many other parts of India. But still, why we are getting that? There's a huge amount, no? What's the percentage of population of Kerala?
It could be
compared to India. So out of 135, we are only 3.5 crore, right?
Yeah, around 2.3%. That's it.
Yeah. So why we are
that's probably because we are very keen in reporting. Manipulations by the government is pretty less. So probably the reporting is good enough. Maybe that is the reason. Also, it is still a less number. 17.5% of the 100 is the less number. I think it's probably because of the more reporting, sir.
Okay.
Otherwise, Kerala is pretty good in the HTI.
Okay, thank you.
Thank you, sir. Thank you so much.
Thank you, Dr. Anuna. Okay, thank you. We are finishing up with the initial set of postures. Thank you, Dr. Hemant Saluja, a good friend of AFPA Kerala, for joining us in this AFPICON 2022. As already introduced initially during the beginning of the poster presentation, he's a big leader for AFPA and IMA Delhi and a great teacher, NB, MRCGP, and much more. We thank you, sir, for joining us during your busy schedule. I also would like to thank Dr. Serin Kyriakos, Spice Route National Chair, for joining us. I would like to thank each resident for presenting wonderful posters and enlightening us. I request all of you to join us for the official inaugural function of AFPICON 22 in the link sent to all the delegates in your mail. And our own Honorable Health Minister, Srimati Veena George, will be inaugurating this same. And we will be gathering again in this same room for remaining poster presentation at 11:30 a.m. And we will start with Dr. Begum Khalida at 11:30. She will present her poster at 11:30 a.m. Thank you all.
Thank you.
For poster presentations, presenters, please assemble here 5 minutes before 11:30. We will start with Dr. Begum Khalida at that time. Thank you. Imagika, we will be joining here back at 11:25.
Okay, sir, noted.
scientific program lined up today, and we have other dignitaries to speak now. So I send my best congratulations and best wishes to all of you and for the success of this conference. And we are very happy to see how AFPI Kerala has evolved and leading not just AFPI but family medicine movement across India. So thank you all. Thank you for inviting me here. Thank you very much.
Thank you, Dr. We invite Dr. Vandana Agarwal, National Secretary, AFPI, for the felicitation speech.
Good morning, everyone. Am I audible?
Yes, ma'am.
Good morning, everyone. My best wishes to the congratulations and best wishes to the Kerala team, past President Dr. Reshmi and present President Dr. Dhanya, and the organizing committee for organizing conference, which is person-centric and very much required in this pandemic wave. So I really appreciate this conference. My regards, Honorary Minister of Health and National President Dr. Raman, Dr. Shazad, Dr. Indu. So I'm really feel proud and honored to be here and be part of this conference. And I am also a part of this pandemic, and currently I'm COVID positive, yes, going through the Omicron. Despite that, I have been working day and night despite my illness. I'm very sure, so everybody else, whoever is there, primary health physicians, despite their health and despite their work schedules, I think they're giving their services to the community throughout. And yes, we primary care physicians are the front line and the torch bearers of this, major part of this healthcare being provided to the community. So yes, together doing wonderful, and I congratulate all of you. Thank you so much.
Thank you, Dr. Vandana Agarwal. We invite to felicitate the event.
Good morning, all. Am I audible?
Yes, ma'am.
Yeah. So why should I give a felicitation to my own team? I still don't understand. But being the executive, I think it is my duty to felicitate the AFPI Kerala team, my own team, for first of all, congratulating the team for going ahead with a conference even in this pandemic situation. The virtual conference twice in a succession is very difficult to manage. Hopefully, we'll have a physical conference next year, fingers crossed. All congratulations to Dr. Dhanya and Shahzad for AFPI Kerala as they are leading it now. And Dr. Indu, Dr. Jisha, and the entire organizing team, my friends, colleagues, all residents and speakers for making this a huge success. Hope the remaining academic feast also excites you, and thank you for inviting me for this felicitation speech. All the best. Thank you.
Thank you, madam. We invite State Secretary AFPI Kerala, Dr. Shahzad MU, for delivering the felicitation.
Good morning. Yeah. First of all, I'm very grateful to be part of this event and to be working with a very enthusiastic organizing team here. FPI Kerala has been very serious in its academic activities, and AFPICON Kerala has been one milestone event that we have always been fond of. The annual state conference. This year again, due to COVID, it's virtual, just like last year. But just like Dr. Reshmi, having a physical event the next time, hopefully. And apart from the academic events, we have also been very closely in follow-up with the policy makers of the state for uplifting the specialty in the state. And yes, the specialty has gained momentum. It has gained a lot of momentum in its recognition for the past few years. And it's a delight to see a lot of new faces with very positive and assuring attitude. On behalf of the national leaders and state leaders, especially Dr. Madam, Dr. Mohan sir, for their constant, wholehearted support in all our ventures. I extend my best wishes to the organizing team and all the participants who are here for this academic feast. Thank you.
Thank you, sir. Next, we welcome Dr. Jishavi, Organizing Secretary, AFPICON Kerala, 2022, for giving vote of thanks.
Good morning, everyone. The job bestowed upon me today is to give my sincere thanks to all of you. First of all, I would like to thank our Honorable Minister of Health and Family Welfare, Dr. Ms. Srimati Veena George, who has given us some time, given us her time in the midst of this ongoing pandemic. I'm sure she is having a very busy schedule, but she took up our invitation and she joined us for this inaugurating our conference. I'm really grateful to Veena Madam for giving her giving us her kind words. Next, I'd like to thank Raman sir. Raman sir has been the pillar of family medicine in India since its inception. Whenever we call him for whatever academic activities, he joins us and he supports us, and his support gives us, makes us want to do more. So I sincerely thank you, Dr. Raman sir, for joining us here today. I'd also like to thank Dr. Vandana ma'am, who's our National Secretary. Ma'am, for our talks, and ma'am has been an inspiration to all of us young doctors who have joined family medicine. When we see her practice and when we see her talk, I, on behalf of AFPICON Kerala, thank you sincerely, Dr. Vandana ma'am. Next, I would like to thank Dr. Danya ma'am, our state president. Ma'am has been our Ma'am has been with us since the beginning of this conference, and it was we planned it and we organized it. And ma'am, it was under ma'am's guidance that we are able to organize this conference here today. I'd like to extend my thanks to Dr. Vandanya ma'am on behalf of the organizing committee for AFPICON Kerala 2022. And I'd like to thank Dr. Reshmi madam. There is no words that I can say that are enough to thank Reshmi ma'am's support for all of us who are family physicians here in Kerala, ma'am. And even on the national stage also, ma'am is now in the national FPA. And ma'am is always there to push us when we are, not doing enough. Is always giving us support and advice. I'd like to thank Dr. Reshmi ma'am for her support. And I'd also like to thank Kerala chapter, and he has been the person, whatever you need, you just call Dr. Shehzad and he's there for us. So I'd like to thank Dr. Shehzad for joining us here today for this inaugural ceremony. And I'd also like to thank all the organizing team who has helped us do this conference, get it on without trouble. And I'd also like to thank all the speakers and chairpersons, all the residents who have participated in the quiz posters, and all of you on the audience who are listening today. I'd like for their for supporting us today. Thank you, everyone. Thank you.
Thank you, Dr. Jisha. With that, we come to the end of the inaugural function. Let us move on to the next session.
Our next session is
Roshni madam, whether Swapna madam has not joined, it seems.
Nadine, we'll wait for her.
Yeah, I'll just connect her. We'll just wait for 2 minutes.
Okay.
She's joining. Hi, Dr. Swapna madam has joined.
Heartiest congratulations to AFPA Telangana team for hosting the 5th National Conference on Family Medicine and Primary Care. I'm immensely privileged and honored to be part of this event. The theme of the conference, Post-COVID Strategies and Strengthening Primary Care and Public Health, cannot be more appropriate. It's a well-established fact that the countries with a strong primary healthcare system have better health outcomes and health indices. For some reasons, primary care sector in our country is ignored over the years. But The ongoing pandemic has brought the limelight
Okay, I can see
Morning.
Dr.
Am
Sapna.
I audible? Just to,
Yeah,
am I
you're
audible?
audible.
Just to, okay,
Yeah,
thank you.
yeah, we'll start. Madam. Am I audible? Imagine I can hear my voice.
Yes, sir, you're audible, but you have joined from.
Sorry?
Please disconnect from one device.
Okay. Okay. Now is it okay?
Yes, sir. Yes, sir.
Okay,
Okay,
we are assuming condition. These postures will be judged by eminent faculty, Dr. Swapna Bhaskar and Dr. Roshni M. I would like to introduce this officially, even though both
Sir, I think you have joined from attending link as well.
Sorry?
Sir, there is lot of echo from
Okay,
your side.
I'll just rejoin them.
Okay, okay.
Sapna, good morning.
Good morning, Roshni.
Is it okay now?
No.
Okay, I'll rejoin them. Am I audible?
Yes, sir, perfect.
Okay, sorry for the confusion. Okay, we are resuming with the poster presentation. We have already done with a set of posters before the inaugural ceremony. Now, the second part of the posters will be displayed now, and these posters will be judged by two eminent faculties, both from AFPI, that is Dr. Swapna Bhaskar from Bangalore and Dr. Roshni M from Kerala. I would like to introduce the judges officially, even though both are familiar faces in AFPI circle and outside in the other medical fraternity for long years. Dr. Roshni M has graduated from Calicut Medical College and did her DNB Family Medicine and MRCGP and had a fellowship in diabetology. She joined as a faculty in Department of Family Medicine at Calicut Medical College in the year 2012 when MD program was started. She was instrumental in setting up the Department of Family Medicine there and its growth during the initial few years. She was involved in setting up the syllabus and exam pattern of MD Family Medicine for Kerala University, Kuhas, and she was former Associate Professor, Department of Family Medicine at DM WIMS Medical College, Wayanad, and is presently working as consultant family physician at Surya Hospital, Wayanad. Her area of subspecialized training include medical education technologies. Dr. Roshni is a founder member of AFPI Kerala and was former vice president of AFPI Kerala. I welcome you, ma'am. And Dr. Swapna Bhaskar has done her DNB Family Medicine and PGDMCH and established the Department of Family Medicine at St. Philomena's Hospital, Bangalore. And she is now the head of the department at St. Philomena's Hospital. And she has IAPC certification in palliative care and holds a certificate in medical ethics from UNESCO. She is the present president of Academy of Family Physicians of India, Karnataka chapter. She does mentorship of PGs in family medicine and is also a resource person for the National Board and an examiner for family medicine. Dr. Swapna was the organizing secretary of FMPCT 2019 and was the organizing chairperson of AFPICON Karnataka 2021. Her special interests are management of lifestyle disease, tuberculosis, and adult vaccination. With these few words, I ask both the judges to take over with the poster presentation. For the next poster presentation, I would like to request Dr. Begum Khalida. And just for your knowledge, as already announced earlier, each poster will get 8 minutes, including the discussion part. After 8 minutes, a bell will be rang to alert you. And after 10 minutes of poster presentation, that poster will be changed and will be followed by subsequent posters. Thank you all. We'll move with the next presentation. Dr. Begum Khalida can start with.
Good morning, everyone. Myself, Dr. Begum Khalida, a third-year resident from Rangaduri Memorial Hospital, Bangalore. So I'm doing a poster presentation on methotrexate toxicity, skin as the victim. Introduction. Methotrexate is an effective but potentially toxic anti-metabolite anti-cancer drug which has been in use since 1960s. It's been used widely in dermatology, oncology, and rheumatology fields. Low-dose methotrexate, that is 15 to 20 milligrams per week, rarely causes serious adverse events. Case description. This 61 male, non-case of psoriasis, since 7 years on methotrexate, 5 milligram weekly thrice, type 2 DM, hypertension since 6 years, on tablet glimepiride, voglibose, metformin, clonidine, telmisartan, and folinic acid also. Presented with oral ulcers, reduced appetite, dysphagia since 3 days. On evaluation, his BP was 170/90 millimeter mercury, pulse rate 96 beats per minute, GRBS 350 milligrams per deciliter. Cutaneous examination showed psoriatic lesions over the legs, chest, and back. Body surface area was less than 10%. Oral cavity showed slowing with bleeding and candidiasis, congested nasal cavity, pitted nails, and normal scalp. Initial investigation showed pancytopenia, AKI. The labs on admission were HB 11.1, total count 1200, platelet 1.46, HbA1c 7.5%, creatinine 2.1 milligram per deciliter. Peripheral smear, normocytic normochromic blood picture with leukopenia with thrombocytopenia. With LFT was within normal limit. Discussion method, case description. Discussion. Methotrexate is a systemic immunosuppressive agent. Sorry, ma'am. Immediately tablet methotrexate was stopped. After dermatology consultation, he was started on folinic acid, IV antibiotics, antifungals, granulocyte colony stimulating factor, emollients, oral steroids, candid mouth pain, proton pump inhibitors, RT feeds, reverse barrier care. Serial monitoring of CBC RFT was done. In view of thrombocytopenia, the count was 7,000. 2-unit SDP was transfused. Later, he had right external otitis media also. Repeat HB was 8.4 gram per deciliter, total count 24,390, platelet 5 lakhs, creatinine 1.3. He improved clinically and discharged. Discussion. Methotrexate is a systemic immunosuppressive agent. It's a folate antimetabolite that binds to an enzyme named dihydrofolate reductase, which ultimately leads to inhibition of DNA synthesis. The most common minor adverse events of methotrexate are stomatitis, headache, nausea, fatigue, anorexia. The feared side effects are myelosuppression. The incidence is 1.5%, pulmonary, hepatic, and renal dysfunction, cutaneous lesions. Cutaneous ulceration may be considered as an early clinical sign of imminent systemic toxicity, and patients may only present with isolated cutaneous lesions also. Risk factors for serious adverse events are initiation or reinstatement of methotrexate after drug hiatus, increase in dose, renal impairment, use of NSAIDs, age more than 55 years, drug interactions, hypoalbuminemia. Or patient reported non-adherence to medication occasionally and reinstatement of the treatment prior to the events. The side effects of methotrexate may occur through dose-dependent or idiosyncratic mechanisms. The latter will occur mainly in cells that proliferate faster, like hematopoietic bone marrow cells, epithelial gastrointestinal tube, and epidermal cells. The message, the particular case was an eye-opener emphasizing on proper history taking, detailed evaluation, and periodic screening for drug-induced complications or side effects. Hence, in-depth knowledge regarding medications and their side effects, safety profile is of prime importance in family practice.
Thank you, Dr. Begum Khalida. That was a very good presentation. Okay, so yeah, you said about the importance of knowing about the drug interactions and drug reactions that can happen. And many of these cases will be coming to the first contact doctor, that will be the family physician, right? So in this case, let me ask you 1-2 things like, did you here the patient was mainly having mucosal lesions, right?
Yes, ma'am.
And did he have any other bleeding manifestations, this patient?
No, ma'am, he didn't have any other bleeding manifestations like hematomesis or melena, nothing he had. Mucocutaneous lesions he had, and on investigation we had AKI and pancytopenia also.
Okay. So what about liver function test, and what about the respiratory complications which might have happened in this patient?
Methotrexate is known for his liver toxicity also, but in our case, his LFT was within normal limit, ma'am, and he didn't have any other respiratory toxicity also.
Okay, so what did you do to find out whether he had any respiratory complaints also in this case?
We have done a chest X-ray, ma'am. It was normal, and in view of his pancytopenia, especially his TC was very low. So we have done other investigation to rule out any other coexisting infections, but nothing he had.
Okay, so what would be your message to primary care physicians regarding this?
Ma'am, as a famous French philosopher told, what I see, what mind knows, that only I sees. So we should have a thorough knowledge about the common complications and what will be the serious adverse events when we are prescribing a drug, so that we can intervene early and we can prevent the serious adverse events, so that we can prevent the fatal toxicities. So a thorough medical history, as well as the reviewing of medical and the common tablets, what they are taking, we have to know properly.
Okay, Dr. Sofna?
Congrats, Dr. Begum, and I think I would congratulate all the speakers initially itself, so that I don't have to say that every time. It's so nice of you to come forward and do this, first of all, to all of you. I just wanted to know, why did you think of just stopping methotrexate? Could it have been an interaction with any of these drugs? Because this patient is on polypharmacy, right?
Yes,
The number of drugs you have put, and I'm sure there would have been few other drugs also. Could it have been a drug interaction, or why do you think that only methotrexate had to be stopped?
Especially in all these combinations, methotrexate is known to all these adverse events, and for sure, definitely he is on all those tablets for 7 years, for a long time, 7 years and 6 years. But since methotrexate is known for its complications like this, we stopped methotrexate. And definitely its mechanism of action also suggests these reactions may be because of methotrexate. And he had, in between, he used to stop these tablets and self-medication again. A reinstatement of the methotrexate was there.
Yeah. So what I would, like you all to do is first always look for drug-drug interactions also. Don't just put the blame on one drug alone. Okay. Look for whenever the patient is on polypharmacy. And like you said, like ma'am asked you very clearly, what is your role as a family physician? One important thing is to make the patient understand the importance of adhering to the drug and compliance, and also to get back to the doctor at any point. Most people try to be very defensive. They try to find out some reasons and not meet the doctor to, okay, this is because of something, food which I ate, those kind of explanations you hear. So compliance is very important, which I think as family physicians, we would be the right people to tell them that, compliance is most important. So this patient, you told methotrexate 5 mg 3 times a week he was taking. Was the patient being treated by family physician or outside doctor? Or
This methotrexate was started by a dermatologist long years back, and no further follow-up was there. He was continuing on his own without a proper follow-up with the dermatologist, and with this side effects he came to us.
Okay, could a high HB, like GRBS you have mentioned as 350, could the high sugars have caused, precipitated all these?
When I went through the various articles, it was not suggesting, ma'am. Impairment in renal function itself can cause this, can aggravate the side effects.
Of the particular drug, you mean?
Yes, ma'am. Especially methotrexate, since it is excreted to the renal tubules.
So probably that is a sudden rise in sugar can flare up the psoriasis. So the patient would have gone back to take methotrexate, which he had stopped sometime, thinking, everything is normal. That's what happens in most patients. I am fine, so I can stop the medicines. That's their attitude. And then when things flare up, It's very, they just think that, okay, let me go back and take this medicine. And as you said, vaccine waning can happen when there is a stoppage and restart of the drug. That is also very important. Okay, so what will you advise the patient now? Instead of methotrexate, will you start methotrexate again, or what will you go ahead now with? What is your next plan of action?
After settling all these acute events, definitely we can start the methotrexate again. But from my side, being a provider, family care physician, I have to explain them why he is taking this medication, what is the mechanism of action, what can happen, what are the common side effects, what are the serious adverse events he may have in the future, and what is the importance of regular follow-up, adherence to the treatment. Everything I have to explain, and the proper hydration, balanced diet, all those things I have to tell him. Then he has to come to me again if he's having any serious adverse events or any unexpected events. And from his part, being a patient, he has to be compliant with the treatment, regular follow-up. He should know why he is taking this medication and what are the side effects, and when he has to come to a doctor again.
Very good. Thank you. Thank you.
Thank you, Dr. Begum.
Thank you.
Thank you, Dr. Begum Khalida. We will move to the next poster. Dr. Abdullah Lamis will present.
Good morning, everybody. Am I audible? Hello?
Yeah, we can.
Yes, sir, you're audible.
Okay. So now I'm going to present a case scenario of DRESS syndrome, which is drug reaction with eosinophilia and systemic symptoms syndrome. It is a severe idiosyncratic multi-system reaction to a drug characterized by fever, skin rash, lymphadenopathy, hematological abnormalities, and internal organ involvement. Usually occurs in patients with some genetic disposition, overengagement or other secondary hyperuricemias here, and which is a potential cause for causing these clinical symptoms. So we had a patient, 64 years old female with no prior comorbidities except for the recently developed gout, for which she was started on allopurinol, and almost 3 to 4 weeks after initiation of the drug, she presented with jaundice, generalized pruritus with skin exfoliation and oral mucosal lesions. Then it reduced urine output and altered sensorium about almost 3 to 4 weeks after this initiation of drug. So on examination, she looked dehydrated, pale, and icteric, and the pulse volume was little on lower side. Then otherwise, CVS and respiratory system examinations were normal. Then neurologically, she was conscious but disoriented. No other focal neurological deficits were found. Then she had diffuse scaling and skin exfoliation involving more than 90% of the body surface area, and a bald tongue and oral mucosal lesions were present. On investigations, her total counts was raised. Hemoglobin was 9.1, and she had hypernatremia and impaired renal and liver functions. She had conjugated hyperbilirubinemia, elevated transaminases, and then urine eosinophils were present. Then blood and urine cultures were sent, which was negative, and other investigations like chest X-ray, USG abdomen, and 2D echo were normal, which ruled out any major lung or a heart involvement. Then skin biopsy, dermatology consultation was done, and skin biopsy was done, which the report showed spongiotic and patchy vacuolar interface dermatitis with necrotic keratinocytes and scattered eosinophils, which can be seen in DRESS syndrome. These features. So we could suspect the possible drug reaction, and stopped the allopurinol, and appropriate fluid and electrolyte corrections were given. Then nutrition management was done. Then skin and eye care then treated with antibiotics, diuretics, and systemic corticosteroids were used to control the symptoms. Then also other supportive care was given. Then serial monitoring of clinical and biochemical parameters was done, and patient got symptomatically improved and discharged after 2 weeks of hospital stay. Then, as a conclusion, these symptoms of Dress syndrome usually manifest 2 to 8 weeks after starting of the offending medicines, average being 3 to 4 weeks usually. Then this prolonged latency periods creates difficulty in diagnosis. Drugs most commonly associated with Dress syndrome are anticonvulsants, then allopurinol, then certain antibiotics like vancomycin, minocycline, and other beta-lactams, then antiretrovirals. So management involves prompt cessation of the associated medicine and providing supportive treatment. Also, the extent of skin involvement and its severity does not always correlate with the extent of internal organ involvement. Then we have to slowly taper the systemic steroids to prevent further flare-ups, or there are chances of further flare-ups even after stopping the medications. So, as a key message, a strong clinical suspicion is required while dealing such cases in general practice, and is important to realize that medications we use can be cause of wide range of reactions ranging from simple rashes to life-threatening conditions. So prescribed drugs whenever absolutely necessary. So being a family physicians, we can do more regarding that aspects and preventing polypharmacy and all. So and to focus on proper history taking, then including medications history while assessing a patient in clinical practice. Thank you. Thank you.
Thank you, Dr. Lemis.
Okay, thank you,
you conveyed the message that it is very important that you know about the drug interactions, drug reactions. Yes. Okay, and yes. We should keep that in mind always when we are writing, and try to avoid polypharmacy. Okay, that is good. So in this case, let me ask you, like, does it occur with the first exposure to the drug or repeated exposures to the drug?
First exposure itself can cause, ma'am.
Usually it is.
Usually.
Long-term exposure, it is happening with the first one.
First exposure.
Okay. Do you need follow-up of this patient? Does it?
Yes, ma'am. Yes. Because it is said that in Dress syndrome, even after stopping of the medications, also later also they can have flare-ups. From the management part, that systemic corticosteroids that we use, that we have to taper it very slowly. So otherwise there are high risk of flare-ups. So we have to counsel the patient regarding that and appropriate management, and also to come back if any such, we have to explain those things to them on discharge.
Sometimes, rarely, autoimmune sequelae also can happen in these patients.
Autoimmune sequelae also.
So follow-up is needed. Okay.
Seen in these cases, like autoimmune thyroiditis. Sorry, ma'am.
What is the eosinophil count in this patient?
Eosinophil count was it was in the CBC it was 8, I think, ma'am. 8.
Okay. So is it a characteristic feature of Dress syndrome?
No, ma'am. In this CBC 8 means it is not. Yeah, it's a characteristic feature of Dress syndrome. In the urine, eosinophils were present, but
also in the
in blood.
Also you were seeing it.
Yes.
So maybe you could mention the count also over here.
Okay.
Was he febrile?
No, ma'am.
He was not febrile over there.
No, not febrile.
Okay. Dr. Swapna?
Yeah. Nice presentation, Dr. Lemis. May I know where you're working?
Thank you. I'm in Rangadhara Hospital, Rangadhara Memorial Hospital, second year DNB Family Medicine Resident, ma'am.
Yeah. Nice to see students coming up very actively. So basically, I want to know why so many investigations were done when the patient didn't even have fever. Blood culture, urine culture, chest X-ray, USG abdomen, 2D echo. Was there any particular other DDs in your mind?
Because it is laboratory is the patient had reduced urine output, and then the Dress syndrome actually it's known for multi-system involvement. So basically, to rule out any other organ systems affected, we have done basic like chest X-ray, and then.
Okay. Do you think all these was needed actually? If you were not in a major hospital, you would have actually done all this?
If not in a tertiary setup, we may not be
probably. Yeah.
doing.
It was a little over-investigated, I guess. Maybe I know you're a student, so that's why I asked you, were you working or are you student? So some things are not in your hands, I understand. Now, what can you do for this patient? Now, will you be able to restart allopurinol at any point of time? Step of management in this. Sure, he needs long-term treatment.
It's better to if it's better to start on other medicines for hyperuricemia. So like other second line drugs like than other febuxostat or probenecid like that. So we better to consider other drugs rather than allopurinol restarting.
Was this patient your patient, or was it referred from rheumatology or some other place? Did this patient actually have gout? Does all hyperuricemias need treatment?
She had acute presentation of gout, ma'am, with tophi and all. So for a symptomatic gout only they have started. Yes, she may require further.
Differential diagnosis which you would keep in this kind of another major life-threatening skin manifestations in most. What would be the other differential which you will keep?
And although rare, like Stephen Johnson's syndrome, toxic SJS, we have to think of.
Has to be kept in mind for such patients. Always keep that also in mind. Okay, because I don't know if I should be, because a lot of mucosal lesions also you have written, and mucosal lesions are more common in SJS and TE than in DRES. That's why I was wondering. Okay, anyway, thank you for the nice presentation.
Okay, thank you.
Thank you, Dr. Abdullah. Next, poster number 11, Dr. Nivedita will present the poster.
Good morning, ma'am. Good morning, ma'am. I'm Dr. Nivedita. I'm DNB. I suppose I'm audible?
Yes. Yes, ma'am, you are audible.
Okay. Thank you. Good morning, ma'am. I'm Dr. Nivedita, doing my DNB Family Medicine final year at Muthoot Hospital, Pathanamthitta. So today, I'll be talking about finding the hidden clues when the patient walks in and giving new meanings. It's all about a patient, a 60-year-old male patient who had diabetes mellitus. He presented with a family medicine OPD with his blood reports for control of blood sugar levels. So the family physician noted that he had high stepping gait while he walked into his OPD. And once his case history was analyzed, it was noted that he had a history of high stepping gait for past 3 months, which was noted by his relatives at first. Now, the patient reported that his gait and balance has worsened in the last 2 months, and his dietary history comprised of proteins, fruits, vegetables, and no significant history of alcohol intake. And he's a retiree staying with his wife and kids. And there was history of similar complaints in his brother. And on physical examination, it was noted that he had bilateral high arched feet, pes cavus deformity, wasting of distal hands, and weakness in upper and lower limbs. And lower limbs, inversion and eversion of ankle was weak bilaterally, and toes flexion and extension was weak bilaterally. Coordination was normal, there was high stepping gait, and on sensory system examination, pain and touch was impaired in bilateral 1.5 medial fingers, left more than right, and bilateral sensory loss in feet. But the patient never complained of any sensory loss or any other symptoms. And Romberg sign was positive, spinal skull normal, no signs of meningeal irritation. And investigations was done. It showed elevated creatine phosphokinase, blood counts were normal, metabolic profile, vitamin B12, thyroid levels all were normal. But his HbA1c, while considering the family physician, was 14, which improved to 6.8 within 3 months of follow-up of, and it was given OHA and dietary adjustments were given. An MRI spine screen was done because the patient complained of low backache, and it showed L4, L5, L5S1 disc herniation with mild bilateral nerve impingement. And nerve conduction study revealed evidence of advanced, predominantly demyelinating motor sensory polyneuropathy. So this all occurred in our family medicine OPD. And from here, we referred the patient to high-end neurological center because the patient had a family history. And more than that, he had a genetic analysis was done in his higher center. When he went there, they advised intravenous immunoglobulin by the neurological center, but he again consulted his family physician whether the IV intravenous immunoglobulin must be taken, but it was not taken at that time because the diagnosis was not confirmed. So the family physician said, like, we can wait for the time being. And the genetic test was done. And in the meantime, the patient had follow-up in a family medicine OPD for his glycemic control, and his glycemic status was improved. And a small dose steroids were given and some muscle relaxant in view of his intervertebral disc prolapse and muscle spasm, following which he had slight improvement. At presently, and after the genetic analysis came, it was diagnosed to be Charcot-Marie-Tooth disease, and autosomal dominant inheritance and heterozygous duplication was found. And it was reported that it was entire PM22 gene was affected. So now the patient is on physiotherapy where stretching exercises is being done, and also fall risk prevention strategies, balance and posture stabilization, all is being done. Ankle foot orthos is also given, and the patient is quite stable and he is happy about it. And genetic counseling was advised, but since due to financial constraints as well as nothing much can be done in Charcot-Marie-Tooth, the quality of life can be improved. So the family physician plays a role in improving, counseling them and supporting them even after the diagnosis made. So the take-home message is, it's not about diagnosing Charcot-Marie-Tooth disease because we never see usual Charcot-Marie-Tooth disease in our OPD. First, you have to analyze your patient the moment the patient walks from your door to the seat. Basically, we will be writing prescription, doing something, and when the patient sits on the seat, we will be lifting our heads. So we might not miss the gait, especially in this case. And the very moment they walk in, we have to pay close attention, as also in this helps in identifying their present condition and even previously missed or misdiagnosed condition. And we have to counsel and follow up the patient. We usually refer patients to higher centers, but we must counsel and follow up those patients because that will help their morale high and help them in getting an accurate treatment and avoid unnecessarily costly treatment and evaluation. And we have to do a proper evaluation prior to refer. That is important because that decreases the burden on the subspecialist to such a degree that they can reach a diagnosis even faster. So we need to advise our patients regarding diagnosis, which has been even given at the specialist center, because we know the patient better, we know their economic background, we know them in and out. So our advices mean a lot to the patient and should also be done to ensure so that no misdiagnosis made or unnecessary treatment is done. In case of this patient who presented with an HbA1c of 14 with FBS of 320 and PPVS of 460 at the time of presentation, his diabetic management was primarily done with diet and lifestyle medication and oral antidiabetic drugs was initiated, and unnecessarily costly medications were not given. And this all has instilled confidence in the patient because even after referral, he has come back to the family medicine OPD for his further follow-up. Thank you.
Thank you, Dr. Nivedita. That was an excellent presentation as far as a family physician is concerned, right? Rather than the case scenario itself, I feel like concentrating more on the principles of family medicine. You have covered a lot of principles over here, right? Can you just tell them which are the principles that you covered over here when you presented this scenario?
Principles which I would like to say, one thing is person-centric medicine. Like rather than we are focusing on two things I have to like to say is we are focusing on the person, his economic background, what he wants, and also not only we are looking for the symptoms what the patient is saying. We are also looking for the clues when the patient, like even when the patient walks in, we are looking for this. We can find out his physical health, emotional health, how well the patient is doing. All these features can be found out, and especially the rapport with the patient. We have the counseling part, especially that is the main key point I think a family physician must do is rather than other people. We know the patient in and out. We can counsel them, follow up them. We can give them the answer their queries. So this all, I think, will instill confidence in the patient about family medicine, family physician, so that they'll definitely come back to us for any other queries as well as for the other follow-up.
That is it. And I also found like one is cost-effective care. You were giving a comprehensive care, a comprehensive care, taking care of all those other factors.
And also coordination of care is also
coordination of care is there, and also continuation of care also, because the patient is coming back to you and you are giving them follow-up care again. Okay, the continuation part is also there. Good counseling skills, good communication skills. Okay, and you're building rapport with the patient so that they have belief in you. They're coming back to you for everything.
Back to you for
Okay, Dr. Family physician's point of view. Okay.
Thank you.
Dr. Swapna?
Yeah, nice presentation again. Like, I just wanted to give one or two comments. Your slide was very crowded. I think you could have taken up a lot of, points which didn't need to be mentioned. Exactly. So we are not here probably to discuss more about Charcot-Marie. We are probably here, like Dr. Ushni said, very clearly pointed out. What could we have done to prevent this? Was there a way we could have prevented this? When you think like, see, every patient is a learning for us. So sometimes there are things which is not under our control. Sometimes there are things which we would think back, what could we have done to prevent this? Is there anything you would have thought, in the next patient, I can do this so that I can prevent this?
But even prevention is a genetic disease. So maybe genetic counseling I can offer, early diagnosis. Basically, I think quality of life can be improved, or rather than early detection is something which we can do. But explaining to them.
Yeah. That's true. I agree. But yeah, what I would like you to do is probably do more sugar control. I mean, the control of sugars
and with lifestyle modification as well as anti-diabetic drugs we're doing. Yes.
Yeah. What test can you do in your OPD to kind of, pick up diabetic neuropathy quickly? One simple test which you can do, which I feel most
monofilament test can be done.
Yeah, so that's something which you should be doing for every patient, so that so that we try and prevent any form of neuropathy, not just Charcot-Marie. Yeah, so that's exactly those are the things which can come in prevention, where you can probably, I'm not telling that this can be prevented, but most of the other complications. So as a family physician, that is one thing which you should take home. And always in your, not just sugar control, going beyond just sugar control also. A fundoscopy, those are things which you should be keeping in mind. If you have a fundoscope, do it, or else refer to I think it's a fundoscope which you can only do in your clinic. Things which can go a lot of way in, and patient ending up in ophthalmic complications or neurological complications. Okay, so try and get down the too much things in the slide to a little more, a little less crowded. Yeah, nice presentation. Thank you.
Thank you, Dr. Nivedita. We will move to the next poster number 12, and it will be presented by Dr. Lebiba.
I start? Am I audible?
Yes, ma'am, you are.
So good morning, one and all. Myself, Dr. Labiba Hamza, third year DNB Family Medicine resident from Medical Trust Hospital, Kochi. So today I would like to present a case scenario on an atypical clinical cause of Onychomycosis purpura. So as primary care physicians will be often challenged with the diagnosis of major illness from common clinical presentations. So here we present how a logical elucidation of symptoms and signs led to the diagnosis and management of HSP or Onychomycosis purpura. So here we encountered an 11-year-old boy who presented with complaints of intermittent colicky abdominal pain for 5 days, and he had multiple episodes of non-bilious vomiting for 1 day. He had no significant past history, natal or postnatal history, and on examination, his vitals were all noted to be stable with normal developmental parameters. But there was mild periumbilical tenderness elicited by the abdomen, but with no features of guarding or rigidity, with other systems all within normal limits. So we considered a provisional diagnosis of an acute abdomen, and then he was treated symptomatically with IV fluids, antiemetics, along with antibiotics. Towards the second day, he was noted to develop loose stools, And on the following day, his condition was noted to worsen with onset of generalized seizures, increasing abdominal pain, and vomiting. So seizures were controlled with anti-epileptics, and then he was shifted to the intensive care for further monitoring and evaluation. So at this point, his history was reviewed. Further examinations revealed a high blood pressure with non-plunging palpable purpuric spots on the right lower leg. And the urine examination also showed presence of RBCs. The rest of the blood investigations were all found to be within normal limits, and a USD abdomen then showed a bowel edema and moderate ascites. So to recapitulate, abdominal pain, hypertension, microscopic hematuria, and purpuric spots pointed towards the possibility of an HSP or Onychomycosis purpura. Few more spots appeared in the next few days with onset of arthritis, and this patient was treated with steroids, and supportive measures also continued, and that brought about complete resolution of symptoms. So to sum up, HSP is a small vessel vasculitis of unknown etiology, mostly affecting children. And the pathognomonic clinical feature here is a purpura, a palpable purpura involving the extensor surfaces and the buttocks. And the organ system mainly involved are the gastrointestinal tract, the kidneys, the central nervous system, and the musculoskeletal system. And it is a self-limiting illness which requires steroids, IVIG, or even plasmapheresis if there is significant GI involvement or any other life-threatening manifestations. So it can also be diagnosed clinically and can also be supported by imaging and biopsy. So to conclude, it is a hypothetical detective method of diagnosis that is very valuable in a primary care setting. And all unnecessary cost and expenditure can be reduced if the diagnostic workup is carried out on clinical lines with resultant good outcome. That's all for today. Thank you.
Thank you, Dr. Labiba. It was a nice presentation. Okay, so you came across this patient from the peripheral center or from the hospital itself?
From the hospital during my pediatric posting, ma'am.
Okay. So in this case, you were saying that he developed loose stools.
Yes.
So did he have any bleeding manifestations over there? Like, was it just loose stools or?
It was just multiple episodes of loose stools. But on the first day, he did not have any complaints of loose stools. And so we just consider possibility of acute gastritis or something like that. But when he developed loose stools, we thought there might be colitis developing within. So it is at this point that we consider an imaging of the abdomen, and that revealed some bowel edema and moderate ascites, and no other clues.
No bloody stools, nothing.
No bloody stools.
No bloody stools. What is the platelet count in this patient?
Platelet count was normal, ma'am. All the blood investigations were noted to be normal limits. Platelet limits was around 2,05,000.
Okay. So in the history, like if you're considering this Onychomycosis, like anything else in the history which might have suggested towards this?
The presentation was more or like just like an acute abdomen. Initially, we just thought of acute appendicitis. Then when he developed colitis part, we thought it could be some enterocolitis or something like that, or any other infectious cause which is contributing to the diarrheal part. But then it is with the seizures that all our diagnostic perspective change.
Okay. And then the renal symptoms also started coming.
Renal parameters till the end, it was within normal, but his BP climbed up and with the seizures, his BP was found to be elevated. And on the next day or on the same day evening, he was noted to have this purpuric spots, and that was the catchy point here, ma'am.
Okay.
So why did you say it is atypical presentation or atypical clinical course? What are the points
usually
that it's atypical?
Yeah, usually a patient with HSP can present with vomiting, abdominal pain, like bloody diarrhea, or hematuria. They can present with bloody stools. And platelets will always be normal, and this purpura will be characteristic, and that will be present in the initial phase itself. This patient presented with purpura later on in the clinical course and not typically in the beginning.
So I think it was on the, for 5 days he had abdominal pain. So the purpura came probably on the 7th day. Okay, so that makes
Purpura
it.
came very late.
Okay, okay. So probably that was one thing to tell that why it was. You didn't explain why it was atypical. That's why I was wondering what made you think this is an atypical presentation. Okay,
Yeah,
and
first year came in the
and
later
for a
on.
biopsy, was a biopsy done or it was just a clinical diagnosis and
Just
steroids?
before starting the steroids for documentation purpose, we had done a skin biopsy, and that showed lymphocytic vasculitis with IgA deposits, and that confirmed our clinical diagnosis now.
Okay, okay. So that's a very valid point, because if you start steroids for some other conditions, you might end up, really harming the patient than doing good.
Yes, ma'am.
Okay. So this boy had come to family medicine OPD or pediatrics?
He presented to the pediatric OPD, and I had encountered this case during the pediatric posting now.
Okay, okay, fine, fine. Do you think anything was missed on day one, like when the patient presented with, intermittent colic, and then was anything missed out? Was there a past history of seizures?
No, nothing of that sort. He had no significant past history or family history. Everything was within normal till the date.
So the patient has had a very, I would say, stormy course in the hospital. Admitted with just what we consider as an acute abdomen, and then seizures, and then hypertension.
Yes,
It's a very, very stormy course. So how would you have explained this to the attenders? Because they would have told, we just got the child with abdomen pain, and now you're telling that he has seizures and high BP.
So on the admission point itself, we had advised them that this admission purpose is for complete evaluation. And then during the course, when he was not responding to our symptomatic management, we had warned them that this could be something else and he will need close monitoring.
Okay, so that's very, very important. Okay, because these are the cases which can end up sometimes, troubling you also, or troubling the hospital as such. Because we walked in with just a colicky abdominal pain of 5 days, and now with so many problems. Yeah, so it's always good. And as family physicians, like Roshima was telling previously, it's our duty to probably warn the patients or think that these could be the differentials which can come out in later on in a few days. But I would say even seizures and all were totally unexpected to me when I was it was looking like totally out of the blue the seizures came. So communicating with the patient becomes very important here, not the patient here, actually the attenders. So I think that's one take home from here, communication clearly to the patient, that so that they don't think, they could even attribute it to a drug after effect, the seizures.
Yes,
Yeah. So communicating is a very important point, I think, which we should, in this discussion part, one extra thing you could add, how to communicate stormy course to the patient. It would be a lesson for you also. I'm sure it would have been, this case would have been a lesson for you, not just in treating an HSP, but in communicating the outcome of what happens when a patient walks in fairly good and then ends up being bad.
Yes, ma'am. Yeah.
Thank you.
But they were happy at the end.
Yes. So yeah, all is good in the end is, a good thing. But then the initial 2 days, I'm sure, would have been a rough time for you all.
Yes.
So that, in fact, I think this should be taken as a study of how to communicate or how to explain things when things go bad. So that also is a lesson from this. Okay. Yeah. Thanks. Nice presentation.
Thank you, ma'am.
Thank you, Dr. Labiba. We will move to the next presentation. That's poster number 13 by Dr. Anaka.
Am I audible?
Yes, ma'am.
Okay. Good afternoon to all. I am Dr. Anaga, DNB resident from Luth Hospital, Kochi. We all know that COVID-19 is highly transmittable and highly pathogenic infection, which cause global pandemic worldwide, and that lead to dramatic loss of human life worldwide. And I will be presenting 2 case scenarios associated with COVID-19. Hello? Hello? Hello?
Yes, ma'am, you are audible.
Okay. I will be presenting 2 case scenarios associated with COVID-19. Moving on to first case, The 52 years old male, non-case of diabetes mellitus, presented with fever, cough, 2-day history of bleeding gums and blood in sputum. On examination, vitals were stable. The petechial lesions are present over hard palate, and system examination were within normal limits. Coming to investigations, the 2-nut SARS-CoV-2 became positive. Total count 14,500. The platelet count was very low, that is less than 15,000. And CRP and ferritins were elevated, but D-dimer was normal. Initially, we thought that this is the case associated with dengue fever, that is COVID-19 plus dengue fever. But dengue NS1 and IgM dengue were negative. The PTAN are normal. Serum procalcitonin, ProPI, ANA by IF were negative. That is the secondary causes of thrombocytopenia like DAC, bacterial sepsis, and connective tissue disorders were ruled out. And also, he was not taking any medication, including antiplatelet or anticoagulant. Then peripheral smear done showed normochromic picture with thrombocytopenia. There was no evidence of abnormal platelet or schistocytes in peripheral smear. Then coming to clinical cause, due to risk of bleeding, the patient was started on platelet transfusion, but still the platelet count was less than 15,000. Due to poor response with this platelet transfusion, he was started on steroid pulse therapy, that is methylprednisolone, 1 gram per day for 3 days. And after 3 days of steroid pulse therapy, the platelet count became 25,000, and he was discharged with oral steroid with tapering dose and asked to review after 5 days. And after 5 days of follow-up, there was no improvement, and the platelet count decreased to less than 5,000, and he was diagnosed as a case of refractory ITP complicated by COVID-19. Then we decided to do bone marrow. The bone marrow done showed normocellular marrow with this megakaryopoiesis. There was no evidence of malignancy or myelodysplastic syndrome in bone marrow. And then hence he was started on thrombopac, 50 milligram per day for 10 days. The platelet count started improving, and then 1 week after discharge, the platelet count became 4 lakh. This is the one interesting case. Then moving on to next case, the 71 years old male with non-case of diabetes mellitus post-COVID 6 months back presented with generalized weakness, weight loss of 15 kg, and recurrent aspiration pneumonia. And he did not take COVID-19 vaccination prior. On examination, looked cachexic, afebrile, and saturation was 92% on room air. Respiratory system examination decreased air entry noted on right side, and the bilateral crackles were present. CNS examination, bilateral element facial palsy present. And on motor examination, power of 3/5 in all 4 limbs, and deep tendon reflexes were absent all over, and the plantar response downgoing bilaterally. Coming to investigation, the chest X-ray showed bilateral infiltrates, that is right more than left. The CT and MRI brain were normal. The nerve conduction study showed sensory motor axonal polyneuropathy, and CSF study showed albuminocytological dissociation, and he was diagnosed as a case of post-COVID GBS. Clinical course, the patient was treated with IV methylprednisolone pulse therapy with significant improvement in his muscle power. Actually, he was advised IVIG, but patient bystanders were not willing because of for financial constraints. And coming to discussion, the COVID-19 associated ITP and GBS can be severe life-threatening and hence warrants rapid and prompt management. Hence, awareness of post-COVID complication helps in survival and early rehabilitation of these patients. Thank you.
Dr. Roshni, I thought, is Dr. Roshni not there? Hello?
Hello.
Yeah,
Okay.
yeah, Roshni. I
Thank
thought you can finish. Yeah.
I just, thank you, Dr. Anagha. That was really well done. The presentation was well done. So your presentation cases over here related to
COVID-19.
COVID, okay. So how frequently, did you look at the literature search? How frequently do you come across this thrombocytopenia happening in immune thrombocytopenia happening?
Madam, thrombocytopenia is happening is very rare, but GBS is more common than this thrombocytopenia. But ITP is very rare. Some studies are have shown, but it is very rare when compared to GBS.
So how frequently do you come across GBS? post-COVID?
GBS is more in our hospital also. There was three or more cases admitted in our neuro department, like post-COVID GBS.
Okay.
But
So
how
many have you come across?
Three cases.
3 cases
Three
during
cases.
this
Yes,
1.5 year period.
Yes, yes.
Okay. Okay. So, here you said the patient had COVID 6 months back. Usually,
yes, ma'am.
Post-COVID, at what time is the usual time of occurrence, like in your literature search or in your experience?
But usually, ma'am, it's occur after 4 weeks after COVID infection. But
Okay.
it is this is a late presentation. Actually, this patient was admitted in our outside hospital for as a recurrent aspiration pneumonia, and he was treated as LRTI. And then again, he admitted in our hospital with aspiration pneumonia and generalized weakness. And after proper history, that is, his wife showed me a photograph of this patient before 6 months. That is before he developing this COVID infection, and that was about 15 kg weight loss following this COVID infection. And after this, after I taking this history, I made a proper evaluation and detailed examination. The examination showed the decreased muscle power, that is 3/5 in all limbs, and a decreased reflexes in all limbs. And so a neurology consultation was given, and the sir advised this nerve conduction study and CSF study. So we make the diagnosis.
Like usually we say it around 6 weeks or 8 weeks time.
Yes.
Okay, but here it is a late presentation.
Late presentation. Actually, if it is diagnosed earlier, that will be very good. That is for the prognosis of this patient. Actually, he's presented as chronic inflammatory demyelinating polyneuropathy, not acute. So the prognosis is very bad comparing that acute presentation.
Okay. Okay.
So the early detection is very important.
I noticed that both your patients are diabetic patients. Do you think diabetic control was good in these patients? Did it play a role?
Yes, ma'am. Very important. It was very important.
Were the patients well controlled with the and diabetes? Both the patients.
Yes, ma'am. Yes.
You mean the HbA1c and all was normal? Because I didn't see a role. Neither I saw the sugars in both the patients. I don't see any sugar values written here.
As madam, after giving this steroid pulse therapy, the sugar values were increasing, but we controlled with insulin at that time.
So insulin was given. In the first case, in ITP, normally we see even a low HB, it's more of a pancytopenic presentation. Here you have given the total count as high. And what was the hemoglobin, if you remember?
Hemoglobin, madam, 11 to 12, 11.5.
11. So it was only a monocytopenia. It was only the platelets coming down. Then, okay. So then what made you think of an ITP?
ITP, sometimes the patient may have primary ITP in the past, and that this infection with COVID-19 may trigger the symptomatic episode now. And more studies have to be done to prove this relationship, actually.
Yeah, ITP can present as monocytopenia also, although we see more pancytopenia in ITP presentations. Okay. In the second patient, why was a CT and an MRI done? Anything in particular which you had in mind why both were done? What was the
Actually,
indication for an MRI here?
He was present with generalized weakness, and that so the MRI was done to rule out any meningitis.
Particularly anything in mind? Just out of curiosity,
No.
I'm asking. Anything was there in mind? Because generalized weakness, weight loss, recurrent aspiration pneumonia shows something chronically going on. So was that the reason to think of doing an MRI, to think of, multiple sclerosis or anything like that? Was that a point? Or was it, MND or anything like that? So keep those also in mind. Maybe that was the reason why. Probably, I'm sure it's a neurologist who must have asked and not probably the primary physician. So what was the need for those two? Okay, so if you're in a peripheral setup, now you're in a tertiary hospital, so you can always ask. In a peripheral setup, you probably won't get all these.
Yes,
you will have to end up doing only what is needed. So maybe you have to think twice before you say CT and MRI for the patients. But little, atypical presentations, I would say, in both the cases. But both were. And what is thrombopag? Just one last question and stop.
Thrombopac, ma'am, thrombopoietin growth factor, platelet growth factor, platelet growth factor. It is an oral tablet, and also it's injection is available, injection romiplastin, subcutaneous injection.
Okay, so you had given the patient tablet or IV?
A tablet, madam. That is, tablet is less costlier than this injection. Injection is very costly.
Okay, so it's used in, what is the indication to use it?
In case of refractory ITP, we can try this Thrombopac, L-Thrombopac.
Okay, fine. Thank you, doctor.
Thank you, thank you.
Thank you, Dr. Anaka. We will now move on to posture number 14. That is, Dr. Minnu is going to present her posture. Over to Dr. Minnu.
Okay. Good afternoon, judges. Good afternoon, my fellow presenters. My topic for today's presentation is the scope of urgent care in family practice. My motto being resolve more and refer less. Well, the spillover of the patient load from primary care settings to tertiary care centers is enormous, leading to a resource mismatch. So family physicians are best positioned to develop practices and provide good quality urgent care to society. So I will be highlighting here the different types of case scenarios we encounter in an urgent care setup of my 12-hour duty in a primary care center. Well, I work in a peripheral hospital called Krista Jayanti Hospital situated in Whitepin. So during my 12-hour period, the wide variety of case scenarios which I witnessed will be enlisted here. Out of the cases, many cases, medicine cases where we had viral fevers, COVID, lower respiratory tract infections, acute exacerbation of COPD, case of anaphylaxis, a case of STEMI, a case of alcohol withdrawal seizure, acute gastritis, a case of hyponatremia, a case of UTI, and also a case of central vertigo. Then in the surgical department, we had a few cases of road traffic accidents requiring involving head injuries. Then a few cases of assault, a case of breast abscess, a case of cellulitis, a case of renal colic, and also a few cases of RTA. Now, in the orthopedic department, we had a case of ankle sprain and a case of shoulder dislocation, anterior shoulders dislocation, and also a case of calcaneum fracture. Then in the case of pediatric department, there was a case of acute respiratory infection pneumonia requiring admission. Then a large number of children coming with incessant cry, and a case of Walry and a case of febrile seizure. Then in the ENT department, there was a case of foreign body throat, also a case of ASOM, and a case of 2 cases of BPPV. In the ophthalm department, there was a case of trauma to the eye causing a corneal abrasion, and a case of foreign body eye, wood dust. And in the dental field, there was a case presenting with toothache. And the kind of OBG department, there were one patient presented with a case of Bartholin cyst, and also with dysmenorrhea, another patient with lower abdominal pain in the antenatal period. Okay, these are the few cases that was enlisted for the 12-hour period. And I've given a few graphical representation of the different cases that I witnessed that day. So from the graphs, it's quite evident that when I triage them into green, yellow, and red, the bulk of the cases, out of total 70 cases, 50 were green, which means easily manageable by us family physicians and did not require referrals. And out of which 12 were yellow and 8 were red and 1 was black. So even the yellow cases could be managed partially. Half of them could be managed there, and half of them required referral. And red obviously managed, initially stabilized, and then referred. Similarly, I've made a breakup of cases as per departments for the 12-hour in ED. As you can see, the vast bulk of patients were from the medicine department, followed by surgery, ortho and pediatric, nearly the same number of cases, followed by ENT, OBG, ophthalm, and dental. Now, in the medicine department itself, as in the category, as you can see, vast number of patients presented with gastric issues, followed by infections, followed by the respiratory cases, then cardiac, and a very few cases presented as neuro cases. In the poster, I've depicted here a few pictures of the cases, not on that 12-hour duty, but during my postings there, which I found attractive. So we have a first picture showing an anterior shoulder dislocation, which was reduced. So a picture before and after. Then there is a picture of a patient who presented with severe abdominal pain, a middle-aged man whose abdomen was very tender and there was guarding and rigidity. And upon taking an X-ray, you could see air under the diaphragm, and he was diagnosed case of perforation and later referred. Then there also a case of non-sustained VT, which presented as palpitations, and she was managed with amiodarone bolus, and then she reverted on that and hence was referred. Similarly, a case of SVT, which came with CHAPS negative, coming with just palpitations and was also reverted. Another case of COVID-19 pneumonia was was identified, admitted, and managed there itself in the peripheral hospital. So these are the few cases I would like to have given pictures of. So I would like to conclude saying that family physicians should be equipped and handed more training to tackle such urgencies so that more number of cases from the peripheral hospitals can be resolved without being referred, thereby increasing the patient welfare and reducing the burden in tertiary hospitals. Thank you.
Thank you, Dr. Meenu. That was a very relevant concept as far as family physicians are concerned. Okay, and this urgent care clinics, actually urgent care centers, maybe you can say that it's actually coming up. And I think that family physicians are to form the foundation of these urgent care centers, right?
Yes, ma'am.
So what do you like? What is your advice? Like, what is your idea? Like, what should we do in order to improve the situation? Like, the family physicians should be very much equipped enough to deal with these urgent cases. Because
Definitely.
as first care physicians, as first contact doctors, we are the ones who see these cases most, right? So what is your suggestion?
So, ma'am, I would like to say that we are very much different from that of an ordinary GP or just a CMO. We are, as family physicians, especially in our when we are doing our PG as in DNB or MD in family medicine, we should be given training enough so that in such peripheral hospitals, when patients come, see, the advantage of a peripheral hospital is that most of the people are very coming from a very poor economic status, so they can't afford a tertiary hospital.
What do you suggest, like, during your training period, maybe you can utilize your specialty postings, optional postings.
Yeah, definitely, ma'am.
For this training. Okay, maybe that will be a good suggestion. Use the optional training months for this. Okay, and maybe another option would be maybe you can go for small fellowship courses.
Yeah, definitely.
For this urgent care alone.
Yeah, we have.
Okay. One thing I would like to advise us, maybe you can format your poster a little bit more better. Like, you have an introduction, you have a conclusion. Okay, so maybe you can do it in the proper format. Like, how do you propose to do it? Okay, because it just has got 2 headings, even though the concept is very good. So the next time maybe you can do that also. Okay.
Definitely, ma'am. Sorry about that.
Great concept again, Dr. Meenu. I just have one query. Okay, now what you're told is emergency medicine. Now, how are you going to differentiate a family physician from this emergency medicine team? So what is the main difference you would say? I would say any person who's emergency medicine trained also would be the same, would do the same thing you have told.
Ma'am, but we are posted in peripheral hospitals, ma'am. And in peripheral hospitals, the bulk load are not the red or yellow. It's mainly green. And the most cases I witnessed were actually requiring OP treatment itself. They come to the casualty just for even for OP cases. So just a CMO would just manage, or an emergency medicine gives priority only for the medicine cases. But as family physician, we can actually deal with almost all their problems. As in, even if it's it's OP or IP, since we are good in managing all of the fields in OP as well as IP as well as ED, we can actually give a wholesome treatment to the patient. Even
Continued care, that's what I would say. Your care doesn't end at the emergency medicine point.
Definitely.
You're
And we
not
can
going to
great
stop the
follow
patient.
up in the OP also.
Exactly. So you will be probably doing a continued care. So if the patient needs an IP, for example, the peritonitis case, you must have referred and admitted. But I'm sure you also should be a part of the treating team and following up the patient and probably, advising on probably the other comorbidities and all that. Whereas an emergency medicine person will just stop at that.
Just refer, and then that's it.
You don't have any continuity there. So you will have a continued care. That is one thing. Okay. And just like ma'am said, a little bit more concept wise, you should have put something more into. It's a very nice concept that you've put up. So do you suggest that the DNB family medicine training program changes from majority of community medicine to majority of emergency medicine?
No, ma'am, not fully, but I would say an equal of both, because we don't know where we might end up. So we just need to be equipped so that we can help our people in the periphery. Also, it's all based on skills, ma'am. So if we are skilled equally in everything, then that'll benefit people. So that's the best thing.
So community medicine is, just dealing with, I would say, softer side of, care. This is more dealing with the harsher side of care. So we need to have a balance of both. So on a lighter vein, when my PGs are, I'm sure family medicine PGs, you all must be going through it, that, you're put in the casualty, you're put in the ICU as extra people when there are no people, because they know we are skilled in everything.
Yeah.
So when my PGs come and complain to me, ma'am, they're asking us to do this extra posting, that extra posting, I say, no, it's a point for you to learn. Especially casualty is one of the places where you learn maximum, because every patient walks through casualty, be it pediatric, be it medicine, be it ENT, be it ortho, ophthal, anything. So that's the biggest learning point for you. So never shy away from casualty extra duties. That is something which I keep telling my PG. So I think it's for all of you, not just, PGs. So all family physicians should have good amount of emergency knowledge, stabilizing the patient and then referring, or stabilizing the patient and keeping them under our care itself. Doesn't. Okay, nice presentation, nice concept also. Thanks.
Thank you.
Thank you, ma'am. Thank you, Dr. Minnu. We'll move to our last poster presentation that's done by Dr. Samina. I would like to invite Dr. Samina for presenting her poster.
Good afternoon. Am I audible, sir?
Yes.
Yes, sir.
Good afternoon, all. I am Dr. Samina, DNB resident at Lowe's Hospital. Depression score among elderly attending community clinic. A comparative study. Ma'am, am I audible? Ma'am, hello.
It's from the
Yes.
They should probably.
May I start?
Yes. Sorry.
Okay. Depression score among elderly attending community clinic. A comparative study. Health status of elderly is becoming even more relevant with demographic shift towards an aging society in Kerala. The review of data suggests prevalence of depression among elderly is very high. However, there is a lack of data on symptom profile and therapeutic intervention for managing the same. So there is a urgent need to conduct large multicentric studies to fill this void in this research. Among various mental disorders, depression accounts for the greatest burden among elderly. Depression decreases the individual's quality of life and increases dependence on others. Elderly in old age home are more prone for depression. Many people experience depression in old age home either as a result of living alone or due to lack of family ties and reduced connection with their culture of origin. As we are having peripheral outreach clinic and old age home visit, we conducted a study regarding depression among elderly. Our aims and objectives are compare prevalence of depression among elderly home residents and elderly old age home residents. Compare depression in the same population in relation to age and gender. Methods and materials. Our study areas is our outpatient community clinic of family medicine department of Lowe's Hospital. Study population was 50 elderly individuals who attended OPD in the month of December 2021. Out of 50, 25 patients were home residents and 25 patients were old age home residents. Study design was cross-sectional study employing interview technique using Beck Depression Inventory Scale. Study sample size was 50 people. In Beck's depression inventory, low level of depression include normal up and downs and mild mood disturbance. Coming to analysis of study, coming to the pie chart showing classification of depression in home and old age home residents. Moderate level of depression is more among home residents and significant level of depression is more among old age home residents. And prevalence of moderate to significant depression among elderly old age home residents was 38%, and in home resident it was 26%. Coming to the classification of depression in home and old age home residents according to age, we can see that as the age advances, the level of depression also increases, and it is more in old age homes. In the 60 to 70 age group, low level of depression is more in home. It's normal actually. Moderate amount of depression is more in old age home, and significant amount of depression is more in home residents. In 70 to 80 and 80 to 90 age group, moderate level of depression is more among home residents, and significant level of depression is more among old age home residents. Coming to the classification according to the gender, we can see that prevalence of depression more among women. And in our study, 50% of elderly were females, and 45% of females were having moderate depression, and 12% of females were having severe depression. Among which 46% of people having moderate depressions were home residents, and 45% of females having moderate depressions were old age home residents. It is almost equal. And 27% of old age home residents females were having severe depression. Coming to the conclusion of our study, prevalence of moderate to significant depression among elderly old age home residents is 38%, and prevalence of moderate to significant depression among home residents were 26%. 8% of old age home residents were having significant level of depression, but only 2% of home residents were having significant level of depression. As the age increases, the level of depression also increases, and moderate to significant level of depression is more in females of both groups. From the study, our conclusions are educate elderly to be aware of their physical and mental health, and peripheral outreach clinic are near their home is essential for elderly care, and to engage elderly in socially active peer groups and promote their recreational activities for them. As a family physician give importance to psychosocial problems along with other health issues.
Thank you.
That's all our recommendations from our study.
Okay, thank you, Dr. Samina. A very relevant topic itself nowadays. Okay, so the geriatric population is increasing, depression is increasing. Okay, so let me ask you, what was your sample size? Do you think it is adequate?
No, it's not adequate. I think
I feel like the sample size is a bit
more
small.
We are planning the study in large group in future.
Okay.
So it's just in 50 people.
Okay.
In 3
so
old
I
age
think
homes.
you need a bigger sample size for
Yeah,
this.
yes, ma'am.
Okay. And then one more thing, like what is the inclusion criteria, exclusion criteria for this study?
We just the patients were selected in random, attending our peripheral clinic above 60.
Like whether they were staying at home, whether they were staying at old age homes.
Yeah,
like that.
We are selected 3 old age home. We are.
Okay.
I go to the 3 old age home and selected 25 patients from there by random method, and 25% patients were from our peripheral outreach clinic.
Okay, so maybe like in the criteria, did you include something like whether they are staying alone at home or whether they are staying in a joint family where they have people around them, or whether the old age home have got such and such number of inmates so that they have company, there are any other facilities available over there, any for them to spend their time. Okay, were all these considered when you did the study?
No, ma'am. So patients were selected in random actually.
Okay. Okay. So maybe the next time you're doing it, maybe all these will be more relevant. Okay.
Exactly.
Marital status, I think in
point Dr. Roshni has
next study we
mentioned.
should include marital status and other health issues
Exactly.
on
Whether,
all.
yes,
All things have to
Did
be
you
considered.
include couples? That was my second part, because Dr. Roshni asked one thing, whether they are staying alone. Now, when you included elders where they're, alone, was the spouse with them? Sometimes, being a widower or a divorcee itself can increase the
Marital
depression.
status and other comorbidities all account to the depression.
Not just marital status, whether the spouse is there with them. So somebody who's a widower, somebody who's, wife is died, I don't think they would definitely be, they will definitely be more depressed than somebody who's staying together. So a couple, elderly couple staying together. So I think there's a lot of subsets to be kept in this, the just two sets of people is not enough. You should have probably analyzed a lot of subsets also. So this is a very, I would say, important study which you have taken up. But half done is the way I would put it. Okay. So because this way it's very difficult. You're just looked at only the physical premises. That's it. You've not looked at anything else, correct?
Yes.
Yeah. And what about the economic conditions of these patients? Are they all from the same economic strata, or are they from different economic strata?
When 25 home residents were from same economic strata as they are at attendance of our peripheral outreach clinics. Now all of them are having low socio-economic status. Old age home residents were from different economic status. Some of them are paid.
Factors for depression, no, like not just one, the place of stay. So place of stay probably is just one of them. So a good concept, but half done. That is my suggestion. So try and do the study in a very good way and try and present it for the national conference if you can. There is a little less time, I know, but if you can, or probably the next state conference, if you can do it's a very good concept which you have taken up. And did you do any comparison with any other studies, national or international, to know whether the people in Kerala are in the same cadre as people outside or internationally?
No, as the sample size is very less, I think
Doesn't matter. See, the percentage, even if the sample size is less, it's kind of a pilot study. No?
Prevalence is almost same.
Same. Okay. Yeah. You can take it as a pilot study. So this is a pilot study with a sample size of 50. Now make it a full-fledged study with a sample size of, at least 500. So this pilot is giving you an idea on what is your shortcomings. So you got suggestions from Roshni ma'am now. So, all of us have given you suggestions. So take this as your pilot study and then do a proper, a proper analysis and suggestions to the old age home too, because I think the old age, as per your study, what I conclude is people in homes are more depressed than in old age homes are more depressed than people who are living in their own houses, right? That is the way you have put it. Yeah. So suggest methods to bring down the depression or to prevent depression, and how it can be tackled. Anybody has, you see, when you say severe depression, there could even be suicidal tendencies. So what if they end up in suicides, and how productive they can be? Yeah. So you can definitely give a lot of suggestions to them to prevent and treat it also, not just by medications. I'm not talking about antidepressants, that anybody can do. I'm talking about the finer aspect of it, or how we can.
I think as a family physician, we can do more. Most of the patients on our peripheral clinic were attending NCD clinic at government setup, even though they come to us because they need to talk to us, and give them more relief.
That's why sometimes it's exactly what like Roshni ma'am said. Sometimes a couple or a person, single person living alone in a house can probably be more depressed than somebody who's living in a community who has a lot of friends and peers around them and common activities to do. So if you see, they have people of their age group, they have common activities to do, they have things to share, they have people to talk. Whereas a person who's staying all alone with his children in US or UK or Australia and all, who can't even have a time to talk to, might be more depressed than somebody who is other way around. So those aspects have to be taken, into consideration before you just put them physically into that. Okay. So otherwise, a very good concept. I think a very good, I would say, study which can be done later.
Okay.
Thank you.
Thank you. Welcome.
Thank you, Dr. Samina, and to judges. we are winding up this session of posture presentation. Any closing remarks from Dr. Roshni Madam or Dr. Sapna Madam is well welcomed.
Roshni, please, after that I will.
No, very interesting concepts were introduced over here. One is this urgent care clinic, then depression and elderly. Okay, then about the drug interactions happening, which we should be aware of. All these, a lot of new ideas have come up, and I hope many have listened to this so that it will be in their mind also. Okay.
Will this be put up in your AFPA Kerala website, these posters and
Sure, madam.
Okay, fine. Yeah. So first of all, congrats to all of you. I think presenting itself makes you winners, leaving alone winning anything. So that first prize, second prize doesn't matter to you. What you have done itself is, coming and presenting and interacting itself is a big thing. My suggestion will be try and take up studies rather than just putting one abnormal case. That is probably for neurosurgeons to discuss or, neurology conference. We are having family physicians conference. So try and take up new concepts like, the last two presenters have done. Let it be a small study. I 100% agree with Dr. Samina, but what she's done is, I would say, a pilot, as I would say. But take up new concepts like this, which would be relevant to family medicine. I wouldn't probably be very impressed with high funda diagnosis or, genomics sequencing and all that. I would be more impressed with these kind of concepts which come up. So that's my suggestion to all of you. And congrats to all. A lot of good interactions, a lot of good discussions. Thanks, Dr. Roshni. I think Dr. Roshni has also pointed out a lot of very significant points which we should keep in mind. Thank you all, and thanks for inviting me also as a judge. That's a big privilege for me. Thank you.
Thank you.
Okay, so to conclude, from the organizing committee of AFPICON 2022, we thank both of our judges for your expert opinion and your valuable time, and all the posture presenting PGs for presenting your work here. And the official announcement regarding the results of the postures will be announced during the valedictory function at 4 p.m. today. And I request all the posture presenters and the judges to be present at that time if time permits. Thank you all. We will wind up this session.
Yeah, Dr. Abuti, shall I send the final marks to your...
Yeah, WhatsApp.
Ma'am, should we go offline? We are online.
Yeah, we can move offline, and we all can gather there in the main conference hall. 2 p.m. post-lunch session will be happening there. Thank you.
Okay, so I'll complete